Chapter 159. Herpes simplex keratitis. Keratitis refers to inflammation of the cornea. The cornea is the outer surface layer that sits in front of the anterior chamber, iris, and pupil at the front of the eye. There are many causes of keratitis. Viral infections, for example herpes simplex, bacterial infection, for example Pseudomonas or Staphylococcus, fungal infection, for example Candida or Aspergillus, contact lens-induced acute red eye or CLAIR, and exposure keratitis caused by inadequate eyelid coverage, for example with ectropion, where the lower eyelid droops outwards and exposes the eye. Herpes simplex virus or HSV infection is the most common cause of keratitis, and this is called herpes simplex keratitis. HSV can cause inflammation of any part of the eye, but most commonly it affects the epithelial layer of the cornea. Herpes simplex keratitis can be primary or recurrent. Recurrence is caused by the virus traveling to the trigeminal ganglion, where it becomes latent or dormant, essentially inactive, and then it can reactivate later. Herpes simplex keratitis usually affects only the epithelial layer of the cornea. Inflammation of the stroma, which is the layer between the epithelium and the endothelium of the cornea, is called stromal keratitis. Stromal keratitis is associated with complications such as stromal necrosis, vascularization, and scarring, and this can lead to corneal blindness. Let's talk about the presentation. Primary infection often involves mild symptoms of blepharoconjunctivitis, which is inflammation of the eyelid margins and the conjunctiva. Recurrent infection may present with a painful red eye, photophobia, vesicles, which are fluid-filled blisters, a foreign body sensation in the eye, watery discharge, and a reduced visual acuity. Slit lamp examination is required to diagnose keratitis. Fluorescein staining shows a dendritic corneal ulcer. Dendritic describes the branching appearance of the ulcer. Corneal scrapings can be taken for viral testing. Finally, let's talk about management. Patients should be referred for urgent assessment and management by an ophthalmologist. Specialist management involves topical or oral antiviral drugs, for example acyclovir or ganciclovir. Corneal transplant is an option for permanent scarring and vision loss after keratitis. Chapter 160. Subconjunctival hemorrhage. Subconjunctival hemorrhage occurs when a small blood vessel within the conjunctiva ruptures, releasing blood into the space between the sclera and the conjunctiva. They often occur after episodes of strenuous activity, such as heavy coughing, weightlifting, or straining when constipated. They can also be caused by trauma to the eye. A Tom tip for you: most cases of subconjunctival hemorrhage are idiopathic in otherwise healthy patients. However, several factors may predispose to the condition and are worth assessing, such as hypertension, bleeding disorders, for example thrombocytopenia or a low platelet count, whooping cough, medications, for example antiplatelet drugs, DOACs or warfarin, and non-accidental injury, where there's safeguarding problems. Let's talk about the presentation. A subconjunctival hemorrhage appears as a patch of bright red blood underneath the conjunctiva. It covers the white of the eye. It's painless and it does not affect vision. There may be a precipitating event such as heavy coughing or heavy weightlifting. Finally, let's go through management. subconjunctival hemorrhage can be confidently diagnosed based on a simple history and examination. Underlying causes should be considered, for example, checking the blood pressure for a high blood pressure and checking the INR for patients who are taking warfarin to see if the INR is out of range. Subconjunctival hemorrhages are harmless and they will resolve spontaneously without any treatment, usually in around 2 weeks. Lubricating eye drops may be helpful if there's mild irritation to the eye. Chapter 161. Posterior vitreous detachment. Posterior vitreous detachment is when the vitreous body comes away from the retina. This is a common occurrence in older age. The vitreous humor is the gel inside the vitreous chamber of the eye. It maintains the structure of the eyeball and keeps the retina pressed up on the choroid. With age, the vitreous humor becomes less firm and less able to maintain its shape. This makes it more likely to change shape and separate from the retina, which is called posterior vitreous detachment. Let's talk about the presentation. Posterior vitreous detachment is a painless condition. It may be completely asymptomatic. The key symptoms are floaters, flashing lights, and blurred vision. Let's talk about the management. No treatment for posterior vitreous detachment is necessary. Over time, the symptoms will improve as the brain adjusts. However, it can predispose patients to developing retinal tears and retinal detachment, both of which are sight-threatening conditions. These conditions can present similarly with flashes, floaters, and vision loss. It's essential to exclude a retinal tear or retinal detachment with a thorough assessment of the retina, usually by an optometrist or an ophthalmologist. Chapter 162. Retinal detachment. Retinal detachment involves the neurosensory layer of the retina, which contains the photoreceptors and the nerves, separating from the retinal pigment epithelium, which is the base layer which is attached to the choroid. Retinal detachment is usually due to a retinal tear, allowing vitreous fluid to get under the neurosensory retina and fill the space between the layers. The neurosensory retina relies on the blood vessels from the choroid for its blood supply. Therefore, retinal detachment can disrupt the blood supply and cause permanent damage to the photoreceptors, making the condition sight-threatening. Let's go through the risk factors. The risk factors for retinal detachment are lattice degeneration, which is thinning of the retina, posterior vitreous detachment, trauma to the eye, diabetic retinopathy, retinal malignancy, and a family history. Let's talk about the presentation. Retinal detachment is a painless condition that can present with peripheral vision loss, which is often sudden and described as a shadow coming across the vision, blurred or distorted vision, and flashes and floaters. Next, let's talk about management. Patients presenting with painless flashes and floaters should have a detailed assessment to detect retinal tears and retinal detachment. Any suspicion of retinal detachment requires immediate ophthalmology referral. Management of retinal tears aims to create adhesions between the retina and the choroid. The options are laser therapy and cryotherapy. Management of retinal detachment aims to reattach the retina and reduce any traction or pressure that may cause it to detach again. The options for reattaching the retina are vitrectomy, scleral buckle, or pneumatic retinopexy. Vitrectomy involves keyhole surgery on the eye, removing the vitreous fluid, fixing the tear, and then inserting gas or oil into the eye to hold the retina in place. Scleral buckling involves using a silicone buckle to put pressure on the sclera from the outside of the eye, squashing the eye inwards and reconnecting the layers of the retina. It acts a bit like a corset, squeezing the eye's contents together. Pneumatic retinopexy involves injecting a gas bubble into the vitreous body and positioning the patient so the gas bubble presses the separated layer back into place. Chapter 163. Retinal vein occlusion. Retinal vein occlusion occurs when a blood clot or a thrombus forms in the retinal veins, blocking the drainage of blood from the retina. The thrombus may form in the central retinal vein or a branch retinal vein. The branch retinal veins drain into the central retinal vein, which runs through the optic nerve to drain into either the superior ophthalmic vein or the cavernous sinus. Blockage of one of the branch veins affects the area drained by that branch. Blockage in the central vein causes problems with the whole retina. The sites where the retinal arteries cross over the top of the veins can cause narrowing of the vein. These sites are at higher risk of occlusion. Blockage of a retinal vein causes venous congestion in the retina. Increased pressure in the retinal veins results in fluid and blood leaking into the retina, causing macular edema and retinal hemorrhages, leading to retinal damage and vision loss. Retinal vein occlusion can be categorized as ischemic or non-ischemic. Ischemia refers to restricted or reduced blood flow and oxygen to a particular tissue. Retinal ischemia leads to the release of vascular endothelial growth factor, or VEGF, resulting in new blood vessel development, which is called neovascularization. Let's talk about the risk factors. The risk factors for retinal vein occlusion are hypertension or high blood pressure, high cholesterol, diabetes, smoking, a high plasma viscosity, for example with conditions like myeloma, myeloproliferative disorders, and inflammatory conditions, for example systemic lupus erythematosus. Next, let's talk about the presentation. Retinal vein occlusion presents with painless blurred vision or vision loss. In branch retinal vein occlusion, the vision loss corresponds to the affected area of the retina. When it involves the branch vein that drains the macula, the central vision is lost. Fundoscopy examination gives characteristic findings of dilated tortuous retinal veins, flame and blot hemorrhages, retinal edema, and cotton wool spots and hard exudates. A tom tip: the fundus in retinal vein occlusion has a blood and thunder appearance, like painted streaks of blood across the surface. This may get confused with the pizza pie appearance of cytomegalovirus or CMV retinitis, which can occur with CMV infection in severely immunocompromised patients, for example end-stage HIV. Finally, let's talk about management. Patients with suspected retinal vein occlusion should be referred immediately to an ophthalmologist. Management in secondary care aims to treat macular edema and prevent neovascularization. The options are anti-VEGF therapies, such as ranibizumab and aflibercept, a dexamethasone intravitreal implant to treat macular edema, and laser photocoagulation to treat new blood vessels. Chapter 164. Central retinal artery occlusion. Central retinal artery occlusion occurs due to obstruction to blood flow through the central retinal artery. The central retinal artery is a branch of the ophthalmic artery, which is a branch of the internal carotid artery. The most common cause is atherosclerosis. It can also be caused by giant cell arteritis, where vasculitis affecting the ophthalmic or central retinal artery reduces the blood flow. Let's talk about the risk factors. The risk factors for cardiovascular disease, for example smoking, hypertension, diabetes, and raised cholesterol, increase the risk of atherosclerosis and central retinal artery occlusion. The risk factors for giant cell arteritis are white ethnicity, older age, female, and polymyalgia rheumatica. Let's talk about the presentation. Blockage of the central retinal artery causes sudden painless loss of vision. It may be described as like a curtain coming down over the vision. On examination, there will be a relative afferent pupillary defect, where the pupil in the affected eye constricts more when light is shone in the other eye than when it's shone in the affected eye. The light input is not sensed by the ischemic retina when testing the direct light reflex, meaning that shining a light in the affected eye does not cause pupil constriction, but the light is sensed by the other eye or the unaffected eye when testing the consensual light reflex, meaning that shining light in the unaffected eye will cause pupil constriction in both eyes. Fundoscopy examination will show a pale retina with a cherry red spot. The retina is pale due to a lack of blood perfusion. The cherry red spot is the fovea, which has a thinner surface and shows the red color choroid below. A tom tip for you, the key differentials for sudden painless vision loss are retinal detachment, central retinal artery occlusion, central retinal vein occlusion, or vitreous hemorrhage due to diabetic retinopathy. Amaurosis fugax describes a temporary loss of vision caused by a temporary interruption to the blood supply. Finally, let's go through management. Central retinal artery occlusion is a sight-threatening emergency. Suspected cases should be referred immediately to an ophthalmologist. Giant cell arteritis is a potentially reversible cause. Testing for giant cell arteritis includes an ESR blood test and a temporal artery biopsy, and treatment is with high-dose systemic corticosteroids. When treating central retinal artery occlusion, immediate management options attempt to dislodge or dissolve the blockage. There's no consensus, guidelines, or solid evidence base for the options. The options are ocular massage, which is essentially massaging the eyeball, anterior chamber paracentesis, which involves removing fluid from the anterior chamber of the eye to reduce the intraocular pressure, inhaled carbogen, which is a mix of 5% carbon dioxide and 95% oxygen, which aims to dilate the artery, sublingual isosorbide dinitrate, which aims to dilate the artery, oral pentoxifylline, which aims to dilate the artery, intravenous acetazolamide, which aims to reduce the intraocular pressure, intravenous mannitol, which aims to reduce the intraocular pressure, and topical timolol, which also aims to reduce the intraocular pressure. Long-term management involves treating reversible risk factors and secondary prevention of cardiovascular disease. Chapter 165: Retinitis pigmentosa. Retinitis pigmentosa is a genetic condition that causes degeneration of the photoreceptors in the retina, particularly the rods. There are many different genetic causes. Some causes involve isolated retinitis pigmentosa, while others result in systemic diseases associated with the condition. The different causes vary in the age at presentation and the prognosis. In most cases, the symptoms start in childhood. Let's start with the presentation. In most causes, the rods degenerate more than the cones. Rods are responsible for night vision and peripheral vision. Therefore, there is night blindness, which is often the first symptom, finding it very difficult to see things in the dark or at night time, and peripheral vision loss before the central vision is affected. Fundoscopy examination shows bone spicule pigmentation. Spicule describes the sharp, pointed appearance. Bone spicule refers to the similarity to the networking appearance of the bone matrix. The pigmentation is most concentrated around the mid-peripheral area of the retina. There can also be narrowing of the arterioles and a waxy or pale appearance to the optic disc. A Tom tip for you, retinitis pigmentosa gives a very characteristic finding on fundoscopy, which will make it popular in OSCE exams. You'll impress your examiners by simply spotting the diagnosis. They're unlikely to expect you to know many other details beside that it's a genetic condition affecting the rods and causing night blindness. Let's talk about the associated systemic diseases. Several genetic systemic diseases involve retinitis pigmentosa. Some examples are Usher syndrome, which also causes hearing loss, Bassen-Cornswig syndrome, which also causes progressive neurological impairments, and Refsum disease, which also causes peripheral neuropathy, hearing loss, and ichthyosis, which is scaly skin. Finally, let's talk about management. General management of retinitis pigmentosa involves referral to an ophthalmologist for assessment, diagnosis, and follow-up, genetic counseling and genetic testing, vision aids, sunglasses to protect the retina from accelerated damage, and driving limitations and informing the DVLA. There is little evidence or consensus on options to slow the disease process at present. Chapter 125. Stroke. Stroke is also called cerebrovascular accident, or CVA. Cerebrovascular accidents are either ischemia or infarction of the brain tissue secondary to a disrupted blood supply, and this is called an ischemic stroke and accounts for about 80 to 90% of strokes, or intracranial hemorrhage with bleeding in or around the brain, and this is called a hemorrhagic stroke and accounts for 10 to 20% of strokes. Ischemia refers to an inadequate blood supply. Infarction refers to tissue death due to ischemia. The blood supply to the brain may be disrupted by a thrombus or an embolus, essentially a blood clot, atherosclerosis, shock with reduced perfusion to the tissues, or vasculitis. Transient ischemic attack, or TIA, involves temporary neurological dysfunction lasting less than 24 hours caused by ischemia but without infarction, so an inadequate blood supply without tissue death. With the TIA, the symptoms have a rapid onset and often they completely resolve before the patient is seen by the emergency room or by their GP. TIAs may precede a stroke. So if a patient's had a TIA, there's a higher probability that they'll go on to have a stroke later on. Crescendo TIAs are 2 or more TIAs within a week and they indicate a high risk of stroke. Let's talk about the presentation. A sudden onset of neurological symptoms suggests a vascular cause, for example a stroke. Stroke symptoms are typically asymmetrical, affecting one side of the body and not affecting the other. Common symptoms are limb weakness, facial weakness, dysphasia or speech disturbance, visual field defects, sensory loss, and ataxia and vertigo. And ataxia and vertigo suggest a posterior circulation infarction. Let's go through the risk factors. The risk factors for a stroke are previous stroke or TIA, atrial fibrillation, carotid artery stenosis, hypertension, diabetes, raised cholesterol, family history, smoking, obesity, vasculitis, thrombophilia, which is a predisposition to developing blood clots, and the combined contraceptive pill. A Tom tip for you: the combined contraceptive pill carries a tiny increased risk of stroke. The risk is significantly increased in patients with migraines with aura, smokers over the age of 34 years, and those with a history of stroke or TIA. Let's talk about the FAST tool. The FAST tool is used as a simple way to identify stroke in the community. F is for face, A is for arm, S is for speech, and T is for time, meaning act fast and call 999. Next, let's talk about the ROSIER tool. The ROSIER tool, which stands for Recognition of Stroke in the Emergency Room, gives a score based on the clinical features and the duration of symptoms. Stroke is possible in patients scoring 1 or more. Next, let's talk about the management of a transient ischemic attack, or TIA. The symptoms should have completely resolved within 24 hours of onset. Initial management of a TIA involves aspirin 300 mg daily, started immediately, referral for specialist assessment within 24 hours, or within 7 days if it's been more than 7 days since the episode, and a diffusion-weighted MRI scan is the imaging investigation of choice. Next, let's talk about management of stroke. The information here is summarized from the NICE guidelines updated in 2022 on stroke. The initial management involves excluding hypoglycemia, or a low sugar level, an immediate CT of the brain to exclude a hemorrhage or bleed, aspirin 300 mg daily for 2 weeks, started after intracranial bleeding has been excluded by the CT scan, because you don't want to give an antiplatelet or a blood thinning agent if the patient has a bleed, and admission to a specialist stroke centre. Thrombolysis with alteplase is considered once a hemorrhage has been excluded after the CT scan. Alteplase is a tissue plasminogen activator that rapidly breaks down clots. It may be given within 4.5 hours of the onset of symptoms based on local protocols and by an appropriately trained team. The main risks with thrombolysis are intracranial or systemic hemorrhage or bleeding, and patients need close monitoring for these complications with access to immediate imaging if bleeding is suspected. Thrombectomy is considered in patients with a confirmed blockage of the proximal anterior circulation or proximal posterior circulation. Thrombectomy is a surgical procedure to remove the clot. It may be considered within 24 hours of the symptom onset and alongside IV thrombolysis. In patients with an ischemic stroke, lowering the blood pressure can worsen the ischemia. Treatment to reduce high blood pressure is only indicated in a hypertensive emergency or to reduce the risks when giving intravenous thrombolysis. Blood pressure is more actively treated in patients with a hemorrhagic stroke. Next, let's talk about the assessment for underlying causes. Patients with a TIA or a stroke are investigated specifically for carotid artery stenosis and atrial fibrillation, with carotid imaging to look for carotid artery stenosis, which may involve a carotid ultrasound or a CT or MRI angiogram, and an ECG or ambulatory ECG monitoring for atrial fibrillation. Anticoagulation is initiated for atrial fibrillation after excluding hemorrhage and finishing the 2 weeks of aspirin. Surgical interventions are considered to treat significant carotid artery stenosis. The options are carotid endarterectomy, which is recommended in the NICE guidelines, or angioplasty and stenting. A Tom tip: the top risk factors to remember for stroke are atrial fibrillation and carotid artery stenosis. All patients with a TIA or a stroke will have carotid imaging and ECGs to try and identify these. Next, let's talk about secondary prevention. Secondary prevention involves clopidogrel 75 mg once a day, or alternatively aspirin plus dipyridamole, atorvastatin 20 to 80 mg daily, and atorvastatin is not started immediately, it's usually delayed for at least 48 hours, blood pressure and diabetes control, and addressing other modifiable risk factors, for example smoking, obesity, and a lack of exercise. Finally, let's talk about rehabilitation. After a stroke, patients require a period of adjustment and rehabilitation, which will involve a multidisciplinary team of stroke physicians, nurses, speech and language therapy to assess swallowing, dietitians in those at risk of malnutrition, physiotherapy, occupational therapy, social services, optometry and ophthalmology, psychology, and orthotics. Chapter 126: Intracranial Hemorrhage. Intracranial hemorrhage refers to bleeding within the skull. There are 4 types: extradural hemorrhage, which is bleeding between the skull and the dura mater; subdural hemorrhage, which is bleeding between the dura mater and the arachnoid mater; intracerebral hemorrhage, which is bleeding into the brain tissue; and subarachnoid hemorrhage, which is bleeding into the subarachnoid space. Intracerebral hemorrhage and subarachnoid hemorrhage account for 10 to 20% of strokes. Extradural hemorrhage and subdural hemorrhage are not typically considered to be strokes. Let's talk about the risk factors. The risk factors for intracranial hemorrhage are head injuries, hypertension or high blood pressure, aneurysms, which are bulges in the artery walls making them prone to rupture, ischemic strokes, which can progress onto bleeding, brain tumours, thrombocytopenia, which is a low platelet count, bleeding disorders, for example haemophilia, and anticoagulants, for example DOACs or warfarin. Next, let's talk about the presentation. A sudden onset headache is the key presenting feature for intracranial hemorrhage. They can also present with seizures, vomiting, reduced consciousness, and focal neurological symptoms, for example weakness. Let's talk about the Glasgow Coma Scale. The Glasgow Coma Scale, or GCS, is a universal assessment tool for the level of consciousness. It's scored based on the eyes, verbal response, and motor response. The maximum score is 15 out of 15, and the minimum score is 3 out of 15. If a patient has a Glasgow Coma Scale score of 8 out of 15 or less, they require airway support, as there's a risk of airway obstruction or aspiration of fluids down into the airway, leading to hypoxia or a low oxygen and a brain injury. Let's talk about extradural hemorrhage. Extradural hemorrhage occurs between the skull and the dura mater and is usually caused by a rupture of the middle meningeal artery in the temporal parietal region. It can be associated with a fracture of the temporal bone. On a CT scan, extradural hemorrhage will have a biconvex shape, and they're limited by the cranial sutures, meaning they do not cross the cranial sutures, which are the points where the skull bones join together. A typical history of an extradural hemorrhage is a young patient with a traumatic head injury and an ongoing headache. They have an initial period of improved neurological symptoms and consciousness, followed by a rapid decline over hours as the hematoma or the collection of blood gets large enough to compress the intracranial contents. Next, let's talk about subdural hemorrhage. Subdural hemorrhage occurs between the dura mater and the arachnoid mater, and it's caused by a rupture of the bridging veins in the outermost meningeal layer. On a CT scan, they have a crescent shape and they're not limited by the cranial sutures, meaning they can cross over the sutures, unlike extradural hemorrhages which are limited by the cranial sutures. Subdural hemorrhages are more common in elderly and alcoholic patients where the vessels are more fragile. Next, let's talk about intracerebral hemorrhage. Intracerebral hemorrhage involves bleeding into the brain tissue. It presents similarly to an ischemic stroke, with sudden onset focal neurological symptoms such as limb weakness, facial weakness, dysphasia or difficulty with speech, or vision loss. Intracerebral hemorrhages can occur spontaneously or secondary to ischemic stroke, tumours, or aneurysm rupture. They can occur anywhere in the brain tissue, which includes a lobar intracerebral hemorrhage, deep intercerebral hemorrhage, intraventricular hemorrhage, basal ganglia hemorrhage, or a cerebellar hemorrhage. Next, let's talk about subarachnoid hemorrhage. A subarachnoid hemorrhage involves bleeding into the subarachnoid space, where the cerebrospinal fluid is located between the pia mater and the arachnoid membrane. This is usually the result of a ruptured cerebral aneurysm. The typical history of a subarachnoid hemorrhage is a sudden onset occipital headache at the back of the head, which comes on during strenuous activity, such as lifting weights or having sex. The sudden and severe onset leads to it being described as a thunderclap headache. Finally, let's talk about the principles of management of an intracranial hemorrhage. Immediate imaging, for example a CT scan of the head, is required to establish a diagnosis. Blood should include a full blood count for the platelets and a coagulation screen. Initial management will involve admission to a specialist stroke centre, discussion with a specialist neurosurgical centre to consider surgical treatment, consider intubation, ventilation, and intensive care if they have reduced consciousness, correct any clotting abnormality, for example a platelet transfusion or vitamin K for warfarin, and correct severe hypertension but avoid hypotension. When controlling the blood pressure, there's a balance between reducing bleeding and maintaining cerebral perfusion. If the blood pressure is too high, there's increased bleeding, but if it goes too low, there's reduced cerebral perfusion. Smaller bleeds may be managed conservatively with close monitoring and repeat imaging. Surgical options for treating extradural or subdural hematomas are a craniotomy, which is open surgery by removing a section of the skull, or burr holes, which are small holes drilled in the skull to drain the blood and relieve the pressure. Chapter 127. Subarachnoid hemorrhage. A subarachnoid hemorrhage involves bleeding into the subarachnoid space, where the cerebrospinal fluid is located between the pia mater and the arachnoid membrane. This is usually the result of a ruptured cerebral aneurysm. Subarachnoid hemorrhage has a very high mortality of around 30% and morbidity, making it essential not to miss. Let's talk about the risk factors. Subarachnoid hemorrhage is more common in people aged 45 to 70 years old, women, and people from a black ethnic origin. The general risk factors for a subarachnoid hemorrhage include hypertension, smoking, and excessive alcohol intake. Subarachnoid hemorrhage is also associated with a family history, cocaine use, sickle cell anemia, connective tissue disorders, for example Marfan syndrome or Ehlers-Danlos syndrome, neurofibromatosis, and autosomal dominant polycystic kidney disease. Let's talk about the presentation. The typical presenting symptom is a sudden onset occipital headache occurring at the back of the head during strenuous activity, such as lifting heavy weights or having sex. This may be described as a thunderclap headache, like being hit hard over the back of the head. Other important features include neck stiffness, photophobia, vomiting, and neurological symptoms, for example, visual changes, dysphasia, vocal weakness, seizures, and reduced consciousness. Let's talk about the investigations. A CT scan of the head is the first-line investigation. Blood will cause hyperattenuation in the subarachnoid space on the CT scan. However, a normal CT head does not exclude a subarachnoid hemorrhage. CT scans are less reliable more than 6 hours after the start of the symptoms. A lumbar puncture is considered after a normal CT head if the diagnosis is still being suspected. The NICE guidelines from 2022 recommend waiting at least 12 hours after the symptoms start before performing a lumbar puncture, as it takes time for the bilirubin to accumulate in the cerebrospinal fluid. With a subarachnoid hemorrhage, the cerebrospinal fluid or CSF sample will show a raised red cell count, and it's worth noting that a decreasing red cell count on successive bottles that are taken during the lumbar puncture may be due to a traumatic procedure, with bleeding occurring from the procedure rather than blood being in the cerebrospinal fluid. And the other important finding on the CSF sample is xanthochromia, which is a yellow color to the sample caused by bilirubin from broken down red blood cells in the CSF. CT angiography is used after confirming the diagnosis to locate the source of the bleeding. Next, let's talk about management. Patients should be managed by a specialist neurosurgical unit. Patients with reduced consciousness may require intubation and ventilation. Supportive care involves a multidisciplinary team during the initial stages and the recovery. Surgical interventions may be used to treat aneurysms. The aim is to repair the vessel and prevent rebleeding. This can be done by endovascular coiling, which involves inserting a catheter into the arterial system. It's an endovascular approach, placing platinum coils into the aneurysm and sealing it off from the rest of the artery. An alternative is neurosurgical clipping, which involves cranial surgery and putting a clip on the aneurysm to seal it. Nimodipine is a calcium channel blocker that's used to prevent vasospasm in patients with subarachnoid hemorrhage. Vasospasm is a common complication following a subarachnoid hemorrhage, and this can result in brain ischemia, so nimodipine is used to prevent this. Finally, let's talk about the management of complications. Hydrocephalus refers to increased cerebrospinal fluid, causing expansion of the ventricles in the brain. Treatment options of hydrocephalus include lumbar puncture to remove some of the cerebrospinal fluid, external ventricular drain, which is a drain inserted into the brain ventricles to drain the cerebrospinal fluid, and a ventriculoperitoneal or VP shunt, which is a catheter that connects the ventricles with the peritoneal cavity in the abdomen. All of these methods aim to drain some of the excess cerebrospinal fluid away from the brain. Seizures following a subarachnoid hemorrhage can be treated with anti-epileptic drugs. Chapter 128: Multiple Sclerosis. Multiple sclerosis, or MS, is a chronic, progressive autoimmune condition involving demyelination in the central nervous system. The immune system attacks the myelin sheath of the myelinated neurons, and we'll talk in more detail about this pathophysiology shortly. Multiple sclerosis typically presents in young adults, in people under the age of 50 years, and it's more common in women. So let's talk in more detail about the pathophysiology. Myelin covers the axons of neurons, of nerve cells, and it helps electrical impulses to travel faster, It's an important coating on the cables that deliver messages around the body. Myelin is provided by cells that wrap themselves around the axons, and these are the oligodendrocytes in the central nervous system and the Schwann cells in the peripheral nervous system. Multiple sclerosis affects the central nervous system and the oligodendrocytes. Inflammation and immune cell infiltration cause damage to the myelin, affecting the electrical signals moving along the neurons. When a patient presents with symptoms of a multiple sclerosis attack, for example an episode of optic neuritis, which we'll talk about in more detail shortly, there are often other demyelinating lesions throughout the central nervous system, most of which are not causing symptoms. In early disease, remyelination can occur, where the myelin recovers and the symptoms resolve. In the later stages of the disease, remyelination is incomplete, and the symptoms gradually become more permanent. A characteristic feature of multiple sclerosis is that the lesions vary in location, meaning that the affected sites and the symptoms change over time. The lesions are described as disseminated in time and space, and this is a description that's worth remembering. The exact cause of multiple sclerosis is unclear, but there's growing evidence that it may be influenced by multiple genes, the Epstein-Barr virus or EBV, having a low vitamin D, smoking, and obesity. Let's talk about the onset. Symptoms usually progress over more than 24 hours. They tend to last days to weeks at the first presentation and then improve. There are many ways that multiple sclerosis can present, which depend on where the lesions are located. Let's talk about optic neuritis, which is the most common presentation of multiple sclerosis. Optic neuritis involves demyelination of the optic nerve, which takes signals from the eye to the brain. It presents with unilateral, reduced vision, with loss of vision on one side, developing over hours to days. Key features of optic neuritis are a central scotoma, which is an enlarged central blind spot, pain with eye movement, impaired color vision, and a relative afferent pupillary defect. A relative afferent pupillary defect is where there is more pupil constriction when shining a light in the contralateral eye than in the affected eye. When testing the direct pupillary reflex, which involves shining a light in an eye to see the pupil response in the same eye, there is a reduced response to shining light in the eye affected by optic neuritis. However, the affected eye has a normal pupil response when testing the consensual pupillary reflex, meaning that when shining light in the unaffected eye, the affected eye will constrict. Multiple sclerosis is not the only cause of optic neuritis. Other causes of optic neuritis include sarcoidosis, systemic lupus erythematosus, syphilis, measles or mumps, neuromyelitis optica, and Lyme disease. Patients presenting with an acute loss of vision need urgent ophthalmology input. Optic neuritis is treated with high-dose steroids. Changes on an MRI scan can help predict which patients will go on to develop multiple sclerosis after a single episode of optic neuritis. Next, let's talk about eye movement abnormalities that can occur with multiple sclerosis. Lesions affecting the oculomotor, trochlear, or abducens nerves, which are cranial nerves 3, 4, and 6, can cause double vision or diplopia and nystagmus. Nystagmus refers to rapid, uncontrolled repetitive eye movements, typically seen as the eyes rapidly moving side to side. Oscillopsia is another visual symptom commonly seen in multiple sclerosis, and it refers to the visual sensation of the environment moving and being unable to create a stable image. Internuclear ophthalmoplegia is caused by a lesion in the medial longitudinal fasciculus. The nerve fibers of the medial longitudinal fasciculus connect the oculomotor nucleus to the abducens nucleus. These fibers are responsible for coordinating the eyes so that they move together. Internuclear ophthalmoplegia causes features when looking to the side. It causes impaired adduction or inward moving on the same side as the lesion, the ipsilateral eye, and nystagmus in the other eye, the contralateral abducting eye. So for example, when looking to the right, the left eye will not adduct and the right eye will have nystagmus. Next, let's talk about focal neurological symptoms. Multiple sclerosis may present with focal weakness, for example, incontinence, Horner syndrome, facial nerve palsy, or limb paralysis. It can present with focal sensory symptoms, for example, trigeminal neuralgia, numbness, paresthesia or pins and needles, and Lermits sign. Lermits sign describes an electric shock sensation that travels down the spine and into the limbs when flexing the neck. It indicates disease in the cervical spinal cord in the neck in the dorsal column. It's caused by stretching the demyelinated dorsal column of the spinal cord in the neck. Transverse myelitis is the term that refers to a site of inflammation in the spinal cord, which results in sensory and motor symptoms depending on the location of the lesion. Next, let's talk about ataxia. Ataxia is a problem with coordinated movement. It can be sensory or cerebellar. Sensory ataxia is due to a loss of proprioception, which is the ability to sense the position of the joint. For example, whether the joint is neutral, flexed, or extended. Sensory ataxia results in a positive Romberg's test, where the patient loses balance when standing with their eyes closed, and it can cause pseudoathetosis, which is involuntary writhing movements because the brain doesn't know where the joint is positioned. A lesion in the dorsal columns of the spine can cause sensory ataxia in patients with multiple sclerosis. Cerebellar ataxia results from problems with the cerebellum coordinating movement, and this indicates a cerebellar lesion in patients with multiple sclerosis. Let's talk about the disease patterns. The disease course of multiple sclerosis is highly variable between individuals. Some patients have mild, relapsing, remitting episodes for life, while others have symptoms that progress without any improvement from the very start. There are classifications used to describe the patterns, which are not separate conditions but part of a spectrum of disease activity. Clinically isolated syndrome describes the first episode of demyelination and neurological signs and symptoms. Patients with clinically isolated syndrome may never have another episode, or they may go on to develop multiple sclerosis. Lesions on an MRI scan indicate a higher probability of developing multiple sclerosis. Relapsing remitting MS is the most common pattern when it's first diagnosed. This is characterized by episodes of disease and neurological symptoms, followed by recovery. The symptoms tend to occur in different areas with each episode. Relapsing remitting MS can be further classified based on whether the disease is active or worsening. Active means that new symptoms are developing or new lesions are appearing on an MRI scan. Not active means no new symptoms or MRI lesions are developing. Worsening means there's an overall worsening of disability over time, and not worsening means there's no worsening of disability over time. Secondary progressive MS is where there was relapsing remitting disease, but now there is a progressive worsening of symptoms with incomplete remissions. the symptoms become increasingly permanent. Primary progressive MS involves worsening disease and neurological symptoms from the point of diagnosis without relapses and remissions. Let's talk about the diagnosis. The diagnosis is made by a neurologist based on the clinical picture suggesting lesions that change in location over time. Remember that term that the lesions are described as disseminated in time and space. Other causes for the symptoms need to be excluded. Investigations that can support the diagnosis include an MRI scan to demonstrate typical lesions and lumbar puncture, which can detect oligoclonal bands in the cerebrospinal fluid. Finally, let's talk about management. A specialist multidisciplinary team manages patients with multiple sclerosis, and this will involve neurologists, specialist nurses, physiotherapists, and occupational therapists. Disease-modifying therapies aim to induce long-term remission with no disease activity. Many options of these target various aspects of the immune system to reduce relapses and disease progression. Relapses of multiple sclerosis may be treated with steroids. The NICE guidelines from 2022 suggest using methylprednisolone, either 500 mg orally daily for 5 days, or 1 gram intravenously daily for 3 to 5 days, where oral treatment has previously failed or the relapses are severe. The other aspect of treatment is to treat the symptoms, and this includes exercise to maintain activity and strength. Fatigue may be managed with amantadine, modafinil, or SSRI antidepressants. Neuropathic pain may be managed with medications, for example amitriptyline or gabapentin. Depression can be managed with antidepressants, such as SSRIs. Urge incontinence may be managed with antimuscarinic medications, for example solifenacin. Spasticity of the muscles may be managed with baclofen or gabapentin, and oscillopsia may be managed with gabapentin or memantine. Chapter 129. Motor Neurone Disease. Motor neurone disease is a term that encompasses a variety of specific diseases affecting the motor nerves. Motor neurone disease is a progressive, eventually fatal condition where the motor neurons stop functioning. The motor neurons are responsible for controlling muscles and muscle movement. Motor neurone disease has no effect on the sensory neurons, meaning that sensation is normal and intact. The presence of sensory symptoms suggests an alternative diagnosis. Amyotrophic lateral sclerosis, or ALS, is the most common and well-known type of motor neurone disease. Stephen Hawking had amyotrophic lateral sclerosis. Progressive bulbar palsy is the second most common form of motor neurone disease, and it primarily affects the muscles of talking and swallowing, the bulbar muscles. Other types to be aware of are progressive muscular atrophy and primary lateral sclerosis. Let's talk about the pathophysiology. Motor neurone disease involves a progressive degeneration of both the upper and lower motor neurons. The exact cause is unclear, although several mechanisms have been considered. Many genes have been linked with an increased risk of developing the condition. Family history is important as around 5 to 10% of cases are inherited. There seems to be an increased risk with smoking, exposure to heavy metals, and certain pesticides. Let's talk about the presentation. The typical patient is a late middle-aged, for example 60 years old, man, possibly with an affected relative. There is an insidious, meaning slow and subtle, progressive weakness of the muscles throughout the body, affecting the limbs, trunk, face, and speech. The weakness is often first noticed in the upper limbs. There may be increased fatigue when exercising. Patients may complain about clumsiness, dropping things more often, or tripping over. They may develop slurred speech, which is called dysarthria. Signs on examination of disease in the lower motor neurons are muscle wasting, reduced muscle tone, fasciculations, which are twitches in the muscles, and reduced reflexes. Signs on examination of disease in the upper motor neurons are increased tone or spasticity of the muscles, brisk reflexes, and an upgoing plantar reflex. Let's talk about making the diagnosis. The diagnosis of motor neuron disease needs to be made very carefully. It's based on the clinical presentation after excluding other conditions, and it should only be made by a specialist when there's certainty. The diagnosis is often delayed, which causes stress. Finally, let's talk about management. There are no effective treatments for halting or reversing the progression of the disease. A medication called riluzole can slow the progression of the disease and extend survival by several months in patients with ALS. Non-invasive ventilation, or NIV, can be used to support breathing when the respiratory muscles weaken. Management of the condition involves supporting the person and their family, which will include breaking bad news effectively and supportively when giving the diagnosis, multidisciplinary team input to support and maintain their quality of life, symptom control, for example, baclofen used for muscle spasticity and antimuscarinic medications for excessive saliva. Benzodiazepines may help breathlessness that's worsened by anxiety. Advanced directives can be used to document the patient's wishes for when the disease progresses, and end-of-life care. Chapter 130: Parkinson's disease. Parkinson's disease is a condition where there is a progressive reduction in dopamine in the basal ganglia in the brain, leading to disorders of movement. The symptoms are characteristically asymmetrical, with one side of the body affected more than the other. The typical patient is an older man, for example around 70 years old, with a gradual onset of symptoms. There is a classic triad of features in Parkinson's disease: a resting tremor, which is a tremor that's worse at rest, rigidity, which is resistance to passive movement of the joints, so the joints become stiff, and bradykinesia, which is slowness of movement. Let's talk about the pathophysiology. The basal ganglia are a group of structures situated near the center of the brain. They're responsible for coordinating habitual movements such as walking, controlling voluntary movements, and learning specific movement patterns. Dopamine plays an essential role in the function of the basal ganglia. Patients with Parkinson's disease have a slow but progressive drop in the production of dopamine. This affects the function of the basal ganglia, causing movement disorders. Let's go through the features. The tremor in Parkinson's is worse on one side, and it has a 4 to 6 Hz frequency, meaning it cycles at 4 to 6 times per second. It's described as a pill-rolling tremor due to the appearance of rolling a pill between the fingertips and the thumb. It's more noticeable when resting, and it improves with voluntary movement. It gets worse when the patient is distracted. If you ask the patient to perform a task with the other hand, for example miming the act of painting a fence, this exaggerates the tremor. Rigidity is resistance to passive movement of a joint. This can be demonstrated by taking a hand and passively flexing and extending the arm at the elbow which demonstrates tension in the arm that gives way in small increments like little jerks. The jerking resistance to movement is described as cogwheel rigidity. Bradykinesia describes the movements getting slower and smaller, and it presents in several ways. The handwriting gets smaller and smaller, and this is called micrographia. Patients take small steps when walking, which is described as a shuffling gait. They have a rapid frequency of steps to compensate for the small steps and avoid falling over, and this is referred to as a festinating gait. There is difficulty initiating movement, for example, going from standing still to walking. They have difficulty turning around in a circle when standing, and they have to take lots of little steps to make a turn. And there's reduced facial movement and facial expressions, which is described as hypomimia. Other features of Parkinson's disease include depression, sleep disturbance and insomnia, loss of the sense of smell, which is called anosmia, postural instability with an increased risk of falling, cognitive impairment, and memory problems. A Tom tip for you: a common exam task challenges you to distinguish between the tremor of Parkinson's disease and benign essential tremor. There are some key features that can help you distinguish these. The tremor in Parkinson's is asymmetrical, while in benign essential tremor, it's symmetrical. Parkinson's tremor has a 4 to 6 Hz, whereas benign essential tremor is 6 to 12 Hz. Parkinson's tremor is worse at rest, while benign essential tremor improves at rest. Parkinson's tremor improves with intentional movement, which makes the tremor worse in benign essential tremor. Patients with Parkinson's likely have other Parkinson's disease features, while in benign essential tremor there's no other features of Parkinson's. And finally, the Parkinson's tremor does not change with alcohol, but alcohol improves the symptoms of benign essential tremor. Let's talk about Parkinson's plus syndromes, which are a group of conditions that include the features of Parkinson's disease plus other features. Multiple system atrophy is a rare condition where the neurons of various systems in the brain degenerate, including the basal ganglia. Degeneration of the basal ganglia leads to the features of Parkinson's. Degeneration in other areas leads to autonomic dysfunction, for example, postural hypotension, constipation, abnormal sweating, and sexual dysfunction, as well as cerebellar dysfunction, including ataxia. Dementia with Lewy bodies is a type of dementia associated with features of Parkinsonism. It causes a progressive cognitive decline, and there are associated features of visual hallucinations, delusions, REM sleep disorders, and fluctuating consciousness. Two other Parkinson's plus syndromes to be aware of are progressive supranuclear palsy and corticobasal degeneration. Next, let's talk about making a diagnosis. Parkinson's disease is diagnosed clinically based on the history and examination findings. The diagnosis should be made by an experienced specialist. The NICE guidelines from 2017 recommend the UK Parkinson's Disease Society Brain Bank clinical diagnostic criteria to help make the diagnosis. Next, let's talk about management. Treatment of Parkinson's is initiated and guided by a specialist, tailored to the individual and their response to different medications. There's no cure for Parkinson's disease, and treatment is focused on controlling the symptoms and having minimal side effects from medications. Patients may describe themselves as being on when the medications are acting and they're moving freely, and off when the medications wear off and they're experiencing symptoms and their next dose is due. The treatment options for Parkinson's disease are levodopa, which is synthetic dopamine, and this is combined with peripheral decarboxylase inhibitors, COMT inhibitors, dopamine agonists, and monoamine oxidase B inhibitors. Levodopa is synthetic dopamine used to boost the patient's level of dopamine to replace the missing dopamine due to the condition. It's usually combined with a peripheral decarboxylase inhibitor, for example carbidopa or benserazide, which stops the levodopa being metabolized in the body before it reaches the brain. Levodopa is the most effective treatment for the symptoms of Parkinson's disease, but it becomes less effective over time. It's often reserved for when other treatments are not adequately controlling the symptoms. Combination drugs of levodopa plus a peripheral decarboxylase inhibitor are cobenaldopa, which is levodopa plus benserazide with the trade name Madapar, or cocaraldopa, which is levodopa plus carbidopa with the trade name Sinemet. The main side effect of levodopa is dyskinesia. Dyskinesia refers to abnormal movements associated with excessive motor activity. Examples are dystonia, which is where excessive muscle contraction leads to abnormal postures or exaggerated movements. Chorea, which are abnormal involuntary movements that can be jerking and random. And athetosis, which is involuntary twisting or writhing movements, usually in the fingers, hands, or feet. Amantadine is a glutamate antagonist that may be used to manage dyskinesia associated with levodopa. COMT inhibitors, for example entacapone, are inhibitors of catechol O methyltransferase, or COMT, which is an enzyme that metabolizes levodopa in both the body and the brain. Entacapone is taken with levodopa and a decarboxylase inhibitor to slow the breakdown of levodopa in the brain. It extends the effective duration of action of the levodopa. Dopamine agonists mimic the action of dopamine in the basal ganglia by stimulating the dopamine receptors. They're less effective than levodopa in reducing symptoms. They're typically used to delay the use of levodopa and then used in combination with levodopa to reduce the required dose. Pulmonary fibrosis is a notable side effect with prolonged use of dopamine agonists. Examples of dopamine agonists are bromocriptine, pergolide, carbergoline, and apomorphine. And finally, monoamine oxidase B inhibitors block the action of monoamine oxidase B enzymes, which helps to increase the circulating dopamine. Monoamine oxidase enzymes break down neurotransmitters such as dopamine, serotonin, and adrenaline. Monoamine oxidase B is more specific to dopamine. Monoamine oxidase B inhibitors are typically used to delay the use of levodopa and then used in combination with levodopa to reduce the end-of-dose worsening of symptoms. Examples are selegiline and rasagiline. A final Tom tip for you: antipsychotics and certain antiemetic drugs, for example metoclopramide and prochlorperazine, work by blocking dopamine receptors, and this can cause drug-induced Parkinsonism. These medications need to be avoided in patients with Parkinson's disease, as you don't want to further reduce the action of dopamine in their brain. Domperidone is a special antiemetic that works by selectively blocking dopamine receptors in the gut and the chemoreceptor trigger zone for nausea without affecting the basal ganglia, and this makes domperidone a suitable choice for treating nausea and vomiting in patients with Parkinson's disease, and this is a commonly tested fact in exams. Chapter 131: Benign Essential Tremor. Benign essential tremor is a relatively common condition associated with older age. It's characterized by a fine tremor affecting all the voluntary muscles. It's most notable in the hands, but it can affect other areas, for example, causing a head tremor, a jaw tremor, and a vocal tremor. Let's talk about the features of benign essential tremor. It's a fine tremor with a 6 to 12 Hz frequency, meaning that it cycles at 6 to 12 per second. It's symmetrical, affecting both sides of the body. It's more prominent on voluntary movement, so when the patient reaches their hand out trying to do something, it makes the tremor more obvious. The tremor gets worse when the patient is tired, stressed, or has taken some caffeine. It tends to improve with alcohol consumption, and the tremor is absent during sleep. Let's talk about the differential diagnosis of a tremor. Benign essential tremor is diagnosed clinically based on the presenting features after excluding other causes of a tremor. Other important causes of a tremor include Parkinson's disease, multiple sclerosis, Huntington's disease, hyperthyroidism, a fever, alcohol withdrawal symptoms, caffeine, and drug-induced, for example with antipsychotic medications. Let's talk about management. There's no definitive treatment for benign essential tremor. The tremor is not harmful and it doesn't require treatment if it's not causing functional or psychological problems. Options for managing the symptoms are propranolol, which is a non-selective beta blocker, and primidone, which is a barbiturate anti-epileptic medication. Chapter 132. Epilepsy. Epilepsy is a condition characterized by seizures. Seizures are transient episodes of abnormal electrical activity in the brain. Let's go through the types of seizure. The types of seizure generally seen in adults include generalized tonic-clonic seizures, partial seizures, which are also called focal seizures, myoclonic seizures, tonic seizures, and atonic seizures. The types that are commonly seen in children include absence seizures, infantile spasms, and febrile convulsions, and we're going to go through all of these in more detail. Generalized tonic-clonic seizures involve tonic, which is muscle tensing, and clonic, which is muscle jerking, movements associated with a complete loss of consciousness. Typically, the tonic phase comes before the clonic phase. So the patient has intense muscle tensing followed by muscle jerking. Generalized tonic-clonic seizures are also called grand mal seizures. Before the seizure, patients might experience aura, which is an abnormal sensation that gives a warning that a seizure is going to occur. They may have tongue biting, incontinence, groaning, and irregular breathing during the seizure. After the seizure, there's a prolonged post-ictal period, which is where the person is confused, tired, and irritable or low. Partial seizures, which are also called focal seizures, occur in an isolated area of the brain, often in the temporal lobes. They may affect hearing, speech, memory, and emotions. Patients stay awake during a partial seizure. They may remain aware during a simple partial seizure, but lose awareness even though they're still awake during a complex partial seizure. There are various symptoms associated with partial seizures, depending on the location of the abnormal electrical activity, such as déjà vu, strange smells, tastes, sight or sound sensations, unusual emotions, or abnormal behaviors. Myoclonic seizures present with sudden brief muscle contractions like an abrupt jump or a jolt. The patient remains awake during myoclonic seizures. They can occur as part of juvenile myoclonic epilepsy in children. Tonic seizures involve a sudden onset of increased muscle tone where the entire body stiffens. This results in a fall if the patient's standing usually falling backwards. Tonic seizures only last a few seconds or at most a few minutes. Atonic seizures, which cause drop attacks, involve a sudden loss of muscle tone, often resulting in a fall. They last only briefly and the patient is usually aware during the episode. Atonic seizures often begin in childhood and they can be indicative of Lennox-Gastaut syndrome. Absent seizures are usually seen in children. The patient becomes blank, stares into space, and then abruptly returns to normal. During an absent seizure, the patient is unaware of their surroundings and they do not respond. They typically last 10 to 20 seconds. Most patients stop having absent seizures as they get older. Infantile spasms are also known as West syndrome. This is a rare 1 in 4,000 disorder that starts around 6 months of age. It presents with clusters of full-body spasms. Hypsarrhythmia is the characteristic EEG finding. It's also associated with developmental regression and it has a poor prognosis. Treatment is with ACTH and vigabatrin. Finally, febrile convulsions are tonic-clonic seizures that occur in children during a high fever. Febrile convulsions are not caused by epilepsy or other pathology such as meningitis or tumors. Febrile convulsions occur in children aged between 6 months and 5 years, and they do not usually cause any lasting damage. 1 in 3 patients will have another febrile convulsion. Having a febrile convulsion slightly increases the risk of developing epilepsy later in life. Let's talk about the differential diagnosis. It's essential to differentiate seizures from other conditions with a similar presentation. Other conditions that can cause episodes that may be confused with seizures include vasovagal syncope, which is fainting, pseudoseizures, which are non-epileptic attacks, cardiac syncope, for example, arrhythmias or structural heart disease causing loss of consciousness, hypoglycemia or a low sugar level, hemiplegic migraine, or a transient ischemic attack. Next, let's talk about the investigations. An electroencephalogram, or EEG, shows typical patterns in different forms of epilepsy and helps to support the diagnosis. An MRI scan of the brain is used to diagnose structural pathology that could cause seizures, such as tumors. Additional investigations can be considered to exclude associated pathology, for example, an ECG for the heart, serum electrolytes, including sodium, potassium, calcium, and magnesium, blood glucose level to look for hypoglycemia and diabetes, and blood cultures, urine cultures, and a lumbar puncture where sepsis, encephalitis, or meningitis is suspected. Next, let's talk about management. Patients and families presenting with seizures are advised about safety precautions and recognizing, managing, and reporting further seizures. Safety precautions include that the DVLA will remove the patient's driving license until specific criteria are met, for example, being seizure-free for 1 year, taking showers instead of baths as there's a risk of drowning with epilepsy, and particular caution with swimming, heights, traffic, and dangerous equipment. Treatment depends on the type of seizure and is guided by a specialist. The aim of treatment is to be seizure-free on the minimum amount of anti-epileptic medications, ideally monotherapy with a single drug. First-line therapies depend on the type of seizure, and this is based on the NICE guidelines from 2022. There is a difference in management between men, women who cannot have children, and women that are able to have children. And this is because sodium valproate is very harmful in pregnancy. Generalized tonic-clonic seizures are treated with sodium valproate in men and women that cannot have children, and they're treated with lamotrigine or levetiracetam in women that are able to have children. Partial or focal seizures are treated with lamotrigine or levetiracetam. Myoclonic seizures are treated with sodium valproate in men or women that cannot have children, or with levetiracetam in women that are able to have children. Tonic and atonic seizures are treated with sodium valproate in men or women that cannot have children, and lamotrigine in women that can have children. And absent seizures are treated with ethosuximide. Other less commonly used antiepileptic drugs to be aware of include carbamazepine, phenytoin, and topiramate. Let's talk in more detail about sodium valproate. Sodium valproate works by increasing the activity of gamma-aminobutyric acid, or GABA, which has a calming effect on the brain. Notable side effects of sodium valproate include that it's teratogenic, meaning harmful in pregnancy, liver damage and hepatitis, hair loss, tremor, and reduced fertility. Sodium valproate in pregnancy can cause neural tube defects and developmental delay. There are strict rules for avoiding sodium valproate in females with childbearing potential, unless there are no suitable alternatives and strict criteria are met. The Valproate Pregnancy Prevention Program is in place to ensure this happens, and this involves ensuring effective contraception and an annual risk acknowledgement form. Finally, let's talk about status epilepticus. Status epilepticus is a medical emergency defined as either a seizure lasting more than 5 minutes or multiple seizures without regaining consciousness in the interim. Management of status epilepticus involves an ABCDE approach, including securing the airway, giving high concentration oxygen, checking the blood glucose levels, and gaining intravenous access, inserting a cannula. Medical treatment for status epilepticus involves a benzodiazepine first line, and this is repeated after 5 to 10 minutes if the seizure continues. Second line options after 2 doses of a benzodiazepine are IV levetiracetam, phenytoin, or sodium valproate. And third line options are phenobarbital or a general anesthesia. The options for benzodiazepines are buccal midazolam, typically 10 mg for adults, rectal diazepam, typically 10 mg for adults, or intravenous lorazepam, typically 4 mg per dose for adults. Chapter 133. Pain. The International Association for the Study of Pain publishes a definition of pain, and this is from 2020. Pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. It's essential to distinguish between 2 categories of pain: acute pain, which has a new onset, or chronic pain, where the pain has been present for 3 months or more. This distinction between acute and chronic pain helps to guide management. Let's talk about the basic physiology of pain. There are 2 aspects to the experience of pain. The sensory aspect, which is the sensory signal transmitted from the pain receptor, and you can think of this as a patient saying it's a sharp sensation like a needle, or it's a dull sensation like an ache. And the affective aspect of pain, and this is the unpleasant emotional reaction to the pain. And you can think of this as a patient saying, it's excruciating, I can't bear it. Pain is supposed to indicate underlying or potential damage to the tissues, but it can occur without tissue damage. The physiology of pain is very complex. there's still a lot that's not fully understood about the experience of pain. Pain is subjective, meaning that when a person indicates they're in pain, we need to accept their experience, even when there's no apparent underlying cause. Pain threshold refers to the point at which sensory input is reported as painful. For example, different temperatures can be applied to the skin to measure the point at which the heat is interpreted as pain. A higher temperature indicates a higher sensory threshold for pain. Allodynia refers to when pain is experienced with sensory inputs that do not normally cause pain, for example, light touching of the skin. Pain tolerance is different to pain threshold. Pain tolerance is more difficult to define and generally refers to a person's response to pain. One person may experience pain but think little of it and carry on with their activities as usual. Another person may experience a similar pain and worry that it indicates a serious underlying illness, take time away from work, and seek medical investigations and treatment. Pain tolerance varies massively between individuals and is influenced by many biological, psychological, and social factors. At the most basic level, pain receptors, or nociceptors, at the ends of nerves detect damage or potential damage to the tissues. Nerve signals are transmitted along the afferent nerves to the spinal cord. Afferent sensory nerves that transmit pain signals are part of the peripheral nervous system and are called primary afferent nociceptors. Two groups of nerve fibers transmit pain. C fibers, which are unmyelinated and have a small diameter, transmit signals slowly and produce dull and diffuse pain sensations. A delta fibers, which are myelinated and have a larger diameter, transmit signals fast and they produce sharp and localized pain. The signal then travels to the central nervous system, up the spinal cord, mainly in the spinothalamic tract and the spino-reticular tract, to the brain where it's interpreted as pain, mainly in the thalamus and the cortex. The main sensory inputs that generate a pain signal are mechanical, for example pressure, heat, and chemical, for example from prostaglandins. However, when directly measuring activity in the peripheral afferent sensory nerves, pain may be experienced without activity in the primary afferent nociceptors, and activity in the primary afferent nociceptors can be detected without the patient experiencing pain. This means patients can experience pain without any apparent peripheral pain signals, and patients can have peripheral pain signals that don't generate a pain response, which makes pain very complex to understand and treat. Referred pain refers to pain experienced in a location away from the site of tissue damage. For example, patients with a heart attack may have pain in their left arm. There are several possible explanations for referred pain, including that nerves may share the innervation of multiple parts of the body, for example, the heart and the left arm. Pain in one area amplifies the sensitivity in the spinal cord to signals coming from other areas, and activation of the sympathetic nervous system in response to pain results in pain in other areas. Neuropathic pain is caused by abnormal functioning or damage to the sensory nerves, resulting in pain signals being transmitted to the brain. Let's talk about measuring pain. There's no reliable ways to objectively measure the pain that somebody is experiencing. As it's a subjective experience, pain is measured by asking the patient about their perception of pain. The Visual Analog Scale, or VAS, involves asking the patient to rate their pain along a horizontal line, where the left end indicates no pain and the right end indicates the worst pain the patient can imagine. The distance along the line can be measured to get a numerical value to represent the patient's pain, for example 75 mm along a 100 mm line. The numerical rating scale, or NRS, involves asking the patient to rate their pain on a numerical scale of 0 to 10, with 0 being no pain at all and 10 being the worst pain they can imagine. Pain can also be rated on a graphical rating scale with a series of faces going from happy to very unhappy. This may be helpful in children or patients with a learning disability. Next, let's talk about the analgesic ladder. The World Health Organization analgesic ladder was originally developed to help manage cancer-related pain. It's also often used for acute and chronic painful conditions. The idea of the analgesic ladder is that patients with mild pain start on the first step of the ladder, and when the pain is more severe or does not respond to the lower steps, then higher steps on the ladder are used until the pain is adequately managed. There are 3 steps to the analgesic ladder. Step 1 is non-opioid medications, such as paracetamol and non-steroidal anti-inflammatory drugs, or NSAIDs. Step 2 is weak opioids, such as codeine and tramadol. And step 3 is strong opioids, such as morphine, oxycodone, fentanyl, and buprenorphine. Tramadol has multiple mechanisms of action, including being a serotonin noradrenaline reuptake inhibitor, or SNRI, and an agonist of opioid receptors. Other medications may be combined with the analgesic ladder for additional effect, and these are called adjuvants. For example, antidepressants such as amitriptyline or duloxetine, or anticonvulsants such as gabapentin or pregabalin. Let's go through some side effects. Medication overuse headache is a common side effect of the long-term use of analgesic medication. Key side effects of non-steroidal anti-inflammatory drugs, or NSAIDs, are gastritis with dyspepsia or indigestion, stomach ulcers, exacerbation of asthma, hypertension or high blood pressure, renal impairment, and coronary artery disease, heart failure, and strokes, which are rare complications. NSAIDs may be inappropriate or contraindicated in patients with asthma, renal impairment, heart disease, uncontrolled hypertension, or stomach ulcers. Proton pump inhibitors, for example omeprazole or lansoprazole, are often co-prescribed with NSAIDs to reduce the risk of gastrointestinal side effects, such as acid reflux, gastritis, and stomach ulcers. The key side effects of opioids are constipation, skin itching, which is called pruritus, nausea, altered mental state with sedation, cognitive impairment, or confusion, and respiratory depression, usually only with larger doses in opioid-naive patients. Naloxone is used to reverse the effects of opioids in life-threatening overdose, usually due to respiratory depression. Let's talk about opioid use in palliative care. Using opioids to control pain in palliative patients is a specific scenario where the doses are titrated and optimized over time. This involves using a combination of background opioids, for example 12-hourly modified-release oral morphine, to give a background dose of opioids, and rescue doses for breakthrough pain, for example immediate-release oral morphine solution. The rescue dose is usually 1/6 of the background 24-hour dose. For example, with a background of 30 milligrams of morphine over 24 hours, for example 15 milligrams modified release morphine every 12 hours, each rescue dose will be 5 milligrams, given every 2 to 4 hours as required. So they have a background of 30 milligrams over 24 hours, divide this by 6 and you have 5 milligrams for the rescue doses. If the patient requires regular rescue doses for breakthrough pain, then the dose of the background opioid needs to be increased. When the background dose is increased, the rescue doses must also be increased to remain 1/6 of the background 24-hour dose. A tom tip for you, remember that each rescue dose is 1/6 of the 24-hour background dose. Exam questions might ask something like, this patient is on 30 milligrams of modified release morphine every 12 hours. What would be the correct breakthrough dose? In this scenario, the answer is 10 milligrams, as the patient is getting 60 milligrams of background morphine every 24 hours, 30 milligrams twice a day. Let's talk about opioid conversion. The information here is from the BNF, which gives approximate conversions between different opiates, giving the dose that's equivalent to 10 milligrams of oral morphine. The conversions are not exact, and different patients respond differently to various opioids. So for example, 10 milligrams of oral morphine is equivalent to 100 milligrams of oral codeine, 100 milligrams of oral tramadol, 6.6 milligrams of oral oxycodone, 5 milligrams of intravenous, intramuscular or subcutaneous morphine, and 3 milligrams of intravenous, intramuscular or subcutaneous diamorphine. It's also possible to use opioid patches to give the background analgesia. For example, buprenorphine patches, where 5 micrograms per hour patches are roughly equivalent to 12 milligrams per 24 hours of oral morphine, or fentanyl patches, where 12 micrograms per hour patches are equivalent to about 30 milligrams per 24 hours of oral morphine. Next, let's talk about chronic pain. Chronic pain refers to pain that has been present or reoccurs in one or more areas over more than 3 months. Up to 50% of adults in the UK are affected by chronic pain. The NICE guidelines on chronic pain from April 2021 separate chronic pain into chronic primary pain, where there's no underlying condition that can adequately explain the pain, and chronic secondary pain, where an underlying condition can explain the pain, for example, osteoarthritis. Biological, psychological, and social factors contribute to the persistence and the severity of chronic pain. Physical processes that can lead to chronic pain include sensitization of the primary afferent nociceptors by frequent stimulation, increased activity of the sympathetic nervous system, and increased muscle contraction in response to pain. Chronic pain is a complex condition that can be challenging to manage. It often fluctuates with flare-ups, and it may get worse over time. Good communication and building a relationship with the patient is important. Part of management aims to maintain the quality of life despite the pain being present. Options for managing chronic primary pain listed in the NICE guidelines from 2021 include supervised group exercise programs, acceptance and commitment therapy or ACT, cognitive behavioral therapy or CBT, acupuncture, and antidepressants, for example, amitriptyline, duloxetine, or an SSRI. The NICE guidelines specifically state that for chronic primary pain, the patients should not be started on paracetamol, NSAIDs, opiates, or anti-epileptic drugs, for example, pregabalin or gabapentin. In chronic secondary pain, where the patient has an underlying physical explanation for the pain such as osteoarthritis or cancer, analgesia may be helpful depending on the underlying cause. For example, in patients with osteoarthritis, the pain may be managed with NSAIDs. A tom tip for you, it's worth remembering that the NICE guidelines clearly state to avoid essentially all forms of analgesia in chronic primary pain, except antidepressants. Chronic primary pain is really common and often these patients have been prescribed many analgesic medications in the past without much benefit. Next, let's talk about neuropathic pain. Typical features of neuropathic pain are numbness, burning, tingling, pins and needles, or an electric shock sensation. Common causes of neuropathic pain include post-hepatic neuralgia from shingles, and this is in the distribution of a dermatome, usually on the trunk, nerve damage from surgery, multiple sclerosis, diabetic neuralgia, typically affecting the feet, trigeminal neuralgia affecting the face, and complex regional pain syndrome. The DN4 questionnaire can be used to assess the characteristics of the pain and the likelihood of neuropathic pain being the explanation. Patients are scored out of 10. A score of 4 or more indicates neuropathic pain. There are 4 first-line treatments for neuropathic pain: amitriptyline, which is a tricyclic antidepressant, duloxetine, which is an SNRI antidepressant, gabapentin, which is an anticonvulsant, and pregabalin, which is also an anticonvulsant. Only one neuropathic medication is used at a time. Tramadol may be used only as a short-term rescue for flares of neuropathic pain. The NICE clinical knowledge summaries from 2022 recommend carbamazepine as the first-line medication for trigeminal neuralgia. Finally, let's talk about complex regional pain syndrome. Complex regional pain syndrome is characterized by areas of abnormal nerve functioning, causing neuropathic pain, abnormal sensations, skin changes, and altered hair growth. It's often triggered by an injury and it's isolated to a single limb. The area can become hypersensitive with pain associated with normal sensations, and this is called allodynia. There may be intermittent swelling of the skin, color changes, temperature changes, skin flushing, and abnormal sweating of the area. Treatment of complex regional pain syndrome is guided by a pain specialist, and it's similar to other types of neuropathic pain. Chapter 134: Facial Nerve Palsy. Facial nerve palsy refers to isolated dysfunction in the facial nerve, and it presents with unilateral facial weakness, with weakness of the facial muscles on one side. Let's talk about the facial nerve pathway. The facial nerve exits the brainstem at the cerebellopontine angle. On its journey to the face, it passes through the temporal bone and the parotid gland. It then divides into 5 branches: the temporal branch, the zygomatic branch, the buccal branch, the marginal mandibular branch, and the cervical branch. Let's talk about the function of the facial nerve. The motor function of the facial nerve controls facial expression, the stapedius muscle in the inner ear, and the posterior digastric, stylohyoid, and platysma muscles. The facial nerve provides sensory function for taste from the anterior 2/3 of the tongue, and it provides the parasympathetic supply to the submandibular and sublingual salivary glands and the lacrimal gland, stimulating tear production. Next, let's talk about a very important task, which is differentiating between upper and lower facial nerve lesions. It's essential to differentiate between upper motor neuron and lower motor neuron facial nerve palsy. Patients with a new onset upper motor neuron facial nerve palsy need immediate management for a possible stroke. In contrast, patients with lower motor neuron facial nerve palsy can generally be managed less urgently. Each side of the forehead has upper motor neuron innervation by both sides of the brain. However, each side of the forehead only has lower motor neuron innervation from one side of the brain. The forehead will be spared in an upper motor neuron lesion, meaning that the patient can move their forehead on the affected side. In a lower motor neuron lesion, the forehead is not spared, and the patient cannot move their forehead on the affected side. So if you ask the patient to raise their eyebrows, if they have an upper motor neuron lesion, they'll be able to raise both eyebrows, but if they have a lower motor neuron lesion, they won't be able to raise their eyebrow on the affected side. Let's talk about upper motor neuron lesions. A unilateral upper motor neuron facial nerve palsy can occur with cerebrovascular accidents or strokes, or tumours. Bilateral upper motor neuron lesions are rare. They may occur in pseudobulbar palsies and motor neuron disease. Next, let's talk about Bell's palsy. Bell's palsy is a relatively common condition. It's idiopathic, meaning there's no apparent cause. It presents with a unilateral lower motor neuron facial nerve palsy. Most patients fully recover from a Bell's palsy over several weeks, but recovery may take up to 12 months. A third of patients are left with some residual weakness. If a patient presents with a Bell's palsy within 72 hours of the symptoms developing, the NICE Clinical Knowledge Summaries updated in 2023 recommend considering prednisolone as a treatment, either 50 mg for 10 days or 60 mg for 5 days, followed by a 5-day reducing regime, dropping the dose by 10 mg per day. Patients also require lubricating eye drops to prevent the eyes from drying out and becoming damaged. Pain in the eye requires an urgent ophthalmology review for exposure keratopathy. The eye can be taped closed at night to prevent damage. Next, let's talk about Ramsay-Hunt syndrome. Ramsay-Hunt syndrome is caused by the varicella zoster virus, or VZV. It presents as a unilateral lower motor neuron facial nerve palsy. Patients stereotypically have a painful and tender vesicular rash in the ear canal, pinna, and around the ear on the affected side. Vesicles are fluid-filled blisters. This rash can extend to the anterior 2/3 of the tongue and the hard palate inside the mouth. Treatment of Ramsay-Hunt syndrome is with acyclovir and prednisolone, and patients also require lubricating eye drops. A Tom tip for you, Ramsay-Hunt syndrome is a popular MCQ exam question. Look out for the patient with a facial nerve palsy and a vesicular rash around their ear, as it's likely to be Ramsay-Hunt syndrome. Finally, let's talk about the other causes of a lower motor neuron facial nerve palsy. And there are many causes that can be broken down into 4 sections: infections, systemic diseases, tumours, and trauma. Infections include otitis media, otitis externa, HIV, and Lyme disease. Systemic diseases include diabetes, sarcoidosis, leukemia, multiple sclerosis, and Guillain-Barré syndrome. Tumours include an acoustic neuroma, parotid gland tumour, and cholesteatoma. And trauma includes direct nerve trauma, surgery, and base of skull fractures. Chapter 135. Brain tumours. Brain tumours range from benign, for example meningiomas, to highly malignant, for example glioblastomas. Let's start with the presentation. Brain tumours may be asymptomatic with no symptoms, particularly when they're small. As they grow, they present with progressive, focal neurological symptoms, meaning signs and symptoms of the nervous system in specific areas, depending on the location of the lesion. Brain tumours often present with signs and symptoms of raised intracranial pressure, high pressure within the skull, and this is also called intracranial hypertension. A growing tumor takes up space within the skull, leaving less space for the other contents, such as the cerebrospinal fluid, and this causes a rise in pressure within the skull. A tom tip for you: a common exam scenario is an unusual change in personality or behavior, which indicates a frontal lobe tumor. The frontal lobe of the brain is responsible for personality and higher level decision making, so a tumor in this area affects personality and behavior. Let's talk in more detail about intracranial hypertension. The causes of raised pressure in the intracranial space include brain tumors, intracranial hemorrhage or bleeding, idiopathic intracranial hypertension, and abscesses or infection. In patients presenting with headaches, the concerning features that may indicate intracranial hypertension include a constant headache, a nocturnal headache occurring at nighttime, a headache that's worse on waking up, a headache that's worse on coughing, straining or bending forward, vomiting, and papilledema on fundoscopy, which we'll talk about in more detail shortly. Other presenting features of intracranial hypertension may include an altered mental state or confusion, visual field defects with an absence of vision in certain areas of the visual field, seizures, particularly partial seizures, unilateral ptosis with drooping of the upper eyelid, and third and sixth cranial nerve palsies affecting the eye movements. Let's talk in more detail about papilledema. Papilledema is a crucial fundoscopy finding in patients with raised intracranial pressure. Papilledema describes swelling of the optic disc at the back of the eye, secondary to raised intracranial pressure. Papille refers to a small, rounded, raised area, the optic disc, and edema refers to the swelling. The sheath around the optic nerve at the back of the eye is connected with the subarachnoid space. Raised pressure in the cerebrospinal fluid, or CSF, flows into the optic nerve sheath, increasing the pressure around the nerve behind the optic disc, causing the optic disc to bulge forward, and this is papilledema. When compared to a normal optic disc, papilledema can be seen on fundoscopy as blurring of the optic disc margin, an elevated optic disc, and a tip is to look at the way the retinal vessels flow across the optic disc to show whether it's elevated or flat, a loss of the venous pulsation, engorged retinal veins, hemorrhages around the optic disc, and Peyton's lines, which are creases or folds in the retina around the optic disc as it bulges forward. A tom tip: when you're looking for the optic disc's elevation, look at how the retinal vessels cross the disc. Vessels travel in a straight line across a flat surface, whereas they'll curve over a raised disc. Next, let's talk about gliomas. Gliomas are tumours of the glial cells in the brain or the spinal cord. Glial cells surround and support the neurons. Glial cells include astrocytes, oligodendrocytes, and ependymal cells. Gliomas are graded from 1 to 4. Grade 1 is the most benign, possibly curable with surgery, and grade 4 is the most malignant, for example, glioblastoma multiforme. The three main types of glioma, roughly from the most to the least malignant, are astrocytomas. The most common and aggressive form is glioblastoma, oligodendrogliomas, and ependymomas. Next, let's talk about meningiomas. Meningiomas are tumours growing from the cells of the meninges. The meninges are the membranes that cover the brain and the spinal cord. Meningiomas are usually benign, however they take up space, and this mass effect can lead to raised intracranial pressure and neurological symptoms. Next, let's talk about secondary metastases. The cancers that most often spread to the brain are lung, breast, renal cell carcinoma, and melanoma on the skin. Next, let's talk about pituitary tumors. Pituitary tumors tend to be benign. If they grow large enough, they can press on the optic chiasm and cause a visual field defect called bitemporal hemianopia, with a loss of the outer half of the visual fields in both eyes. Pituitary tumors can cause hormone deficiencies, which is called hypopituitarism, or they can release excessive hormones leading to acromegaly, which is excessive growth hormone, hyperprolactinemia, which is excessive prolactin, Cushing's disease due to excessive ACTH and cortisol, and thyrotoxicosis, which is excessive thyroid hormones due to excessive release of thyroid-stimulating hormone by the pituitary. Pituitary tumors may be managed with transsphenoidal surgery, which is through the nose and the sphenoid bone, radiotherapy, and hormone-blocking treatments, depending on the excessive hormone. For example, bromocriptine used to block excessive prolactin. Next, let's talk about acoustic neuromas. Acoustic neuromas are benign tumors of the Schwann cells that surround the auditory nerve, the vestibulocochlear nerve that innervates the inner ear. Schwann cells provide the myelin sheath around neurons in the peripheral nervous system. Acoustic neuromas are also called vestibular schwannomas. Acoustic neuromas occur at the cerebellopontine angle, and they're sometimes called cerebellopontine angle tumors. They're usually unilateral, and bilateral acoustic neuromas are associated with neurofibromatosis type 2. If you see a patient with bilateral acoustic neuromas in your exams, they most likely have neurofibromatosis type 2. The typical patient with an acoustic neuroma is a 40 to 60-year-old presenting with a gradual onset of unilateral sensorineural hearing loss, which is often the first symptom, unilateral tinnitus, dizziness or imbalance, a sensation of fullness in the affected ear, and a facial nerve palsy if the tumor grows large enough to compress the facial nerve. Management options for acoustic neuromas include conservative management with monitoring if there's no symptoms or treatment is inappropriate, surgery to remove the tumor, which may be a partial or total removal, or radiotherapy to reduce the growth of the tumor. Finally, let's talk about management in general of brain tumors. MRI scanning is the first-line investigation in patients with a possible brain tumor. A biopsy gives the definitive histological diagnosis to tell you which type of tumor it is, and this is usually obtained during surgery to remove the tumor. The management of brain tumors depends on the type and the grade, guided by the multidisciplinary team. The main options are surgery, and craniotomy refers to removal of part of the skull to access the brain and remove the tumor, chemotherapy, radiotherapy, and palliative care. Chapter 136: Huntington's Disease. Huntington's disease, also called Huntington's chorea, is an autosomal dominant genetic condition that causes progressive neurological dysfunction. It's a trinucleotide repeat disorder, which involves a genetic mutation in the HTT gene on chromosome 4, which codes for the Huntingtin or HTT protein. Symptoms of Huntington's disease typically begin aged 30 to 50. Let's talk about trinucleotide repeat disorders. Nucleotides are the building blocks of DNA, and they include adenine, cytosine, guanine, and thymine. Trinucleotide repeats refer to repetitions of a sequence of 3 nucleotides, for example CAG, 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 CAG. Other examples of trinucleotide repeat disorders include Fragile X syndrome, spinocerebellar ataxia, myotonic dystrophy, and Friedreich ataxia. Let's talk about anticipation. Huntington's chorea displays a feature called genetic anticipation. Anticipation occurs with trinucleotide repeat disorders, where successive generations of affected individuals have more repeats in the gene, and this results in an earlier age of onset and an increased severity of disease. A Tom tip for you: anticipation is a common concept tested in exams, and it's worth remembering with Huntington's disease. Let's talk about the presentation. Huntington's chorea presents with an insidious, progressive worsening of symptoms. It typically begins with cognitive, psychiatric, or mood problems, and these are followed by the development of movement disorders. Chorea refers to involuntary, random, irregular, and abnormal body movements. Dystonia refers to abnormal muscle tone, leading to abnormal postures. Rigidity refers to increased resistance to the passive movement of a joint. Other movement problems include eye movement disorders, dysarthria, which is speech difficulties, and dysphagia, which refers to swallowing difficulties. Next, let's talk about management. A diagnosis of Huntington's disease is made by genetic testing via a specialist genetics center, and it involves pre- and post-test counseling. There are currently no treatment options for slowing or stopping the progression of the disease. Management of the condition involves supporting the person and their family, which will include breaking bad news effectively and supportively, genetic counseling regarding relatives, pregnancy, and children, multidisciplinary team input to support the patient and maintain their quality of life, physiotherapy to improve mobility, maintain joint function, and prevent contractures, which is where the muscles tighten around the joint and cause the joint to lose its range of motion, speech and language therapy, where there are speech or swallowing difficulties. Tetrabenazine may be used to help the chorea symptoms. Antidepressants, for example SSRIs for depression. Advanced directives to document the patient's wishes as the disease progresses. And then end-of-life care. A Tom tip for you: an exam scenario may have you counsel someone about getting a genetic test for Huntington's disease. The child of someone with the disease has a 50% chance of inheriting the faulty gene. It's autosomal dominant. They need to be 18 before they can decide whether to get tested. Your job in this scenario is to provide information for the patient to make an informed decision for themselves, not to advise them whether to get the test or not. The outcome is usually that the patient will think about it further and return if they have further questions. Finally, let's talk about the prognosis. Huntington's chorea is a progressive condition. Life expectancy is around 10 to 20 years after the onset of symptoms. As the disease progresses, patients become more frail and susceptible to illnesses, for example, infections, weight loss, falls, and pressure ulcers. Death is often due to aspiration pneumonia due to swallowing difficulties. Suicide is also a common cause of death. Chapter 137: Myasthenia gravis. Myasthenia gravis is an autoimmune condition affecting the neuromuscular junction. It causes muscle weakness that progressively worsens with activity and improves with rest. Myasthenia gravis affects men and women at different ages, typically affecting women under 40 and men over 60. There's a strong link between myasthenia gravis and thymomas, which are thymus gland tumors. 10 to 20% of patients with myasthenia gravis have a thymoma. Around 30% of patients who have a thymoma develop myasthenia gravis. Let's go through the pathophysiology. Motor neurons communicate with muscles via the neuromuscular junction. On one side of the synapse is the presynaptic membrane of the axon terminal of the motor neuron, essentially the end of the motor neuron. On the other side of the synapse in the neuromuscular junction is the postsynaptic membrane of the motor end plate of the muscle cell. The axons of the motor neurons release a neurotransmitter called acetylcholine from the presynaptic membrane. The acetylcholine travels across the synapse and attaches to receptors on the postsynaptic membrane, and this stimulates muscle contraction. Acetylcholine receptor antibodies are found in most patients with myasthenia gravis. These antibodies bind to the postsynaptic acetylcholine receptors, blocking them and preventing stimulation by acetylcholine. The more the receptors are used during muscle activity, the more they become blocked. There is less effective stimulation of the muscle with increased muscle activity. With rest, the receptors are cleared and the symptoms improve. These acetylcholine receptor antibodies also activate the complement system of the immune system within the neuromuscular junction, and this leads to cell damage at the postsynaptic membrane, which further worsens the symptoms. There are two other types of antibody that can cause myasthenia gravis: muscle-specific kinase, or MuSK antibodies, and low-density lipoprotein receptor-related protein 4, or LRP4 antibodies. MuSK and LRP4 are important proteins for the creation and organization of the acetylcholine receptors. Destruction of these proteins leads to inadequate acetylcholine receptors on the postsynaptic membrane. Let's talk about the presentation. The symptoms of myasthenia gravis vary dramatically between patients, ranging from mild symptoms to life-threatening. The critical feature to look out for is weakness that worsens with muscle use and improves with rest. Symptoms are typically best in the morning and worst at the end of the day. The symptoms most affect the proximal muscles of the limbs and the small muscles of the head and neck, and this causes difficulty climbing stairs, standing from a seat or raising the arms overhead. Weakness of the extraocular muscles causes double vision or diplopia. Weakness of the eyelid muscles causes drooping of the eyelids or ptosis. There can also be weakness in facial movements, difficulty swallowing, jaw fatigue when chewing, and slurred speech. When examining a patient, there are a few ways to elicit fatigability in the muscles, meaning that you're demonstrating that with extra use the muscles become weaker. You can ask the patient to repeatedly blink, and this will exacerbate the ptosis or the drooping of the eyelids. You can ask them to look upwards for a prolonged period, which will exacerbate diplopia or double vision on further testing of the eye movements. And you can ask them to abduct one of the arms 20 times in a row, meaning lifting the arm straight out to the side. And on further testing, there will be unilateral weakness when you compare both arms. Further examination steps include checking the patient for a thymectomy scar and testing the forced vital capacity, or FVC, to test the strength of the muscles of respiration. Next, let's talk about investigations. Antibody tests can be used to look for acetylcholine receptor antibodies, which are found in around 85% of patients, MuSK antibodies in less than 10% of patients, and LRP4 antibodies in less than 5% of patients. A CT or MRI scan of the thymus gland is used to look for a thymoma. And finally, the edrophonium test can be helpful where there's doubt about the diagnosis. So let's talk in more detail about the edrophonium test for myasthenia gravis. Patients are given intravenous edrophonium chloride or alternatively neostigmine. Normally, cholinesterase enzymes in the neuromuscular junction break down acetylcholine. Edrophonium blocks these enzymes, reducing the breakdown of acetylcholine. As a result, after intravenous edrophonium, the level of acetylcholine at the neuromuscular junction rises, temporarily relieving the weakness in patients with myasthenia gravis. And a positive result suggests a diagnosis of myasthenia gravis. Next, let's talk about treatment options. Treatment options include pyridostigmine, which is a cholinesterase inhibitor that prolongs the action of acetylcholine and improves symptoms. Immunosuppression, for example prednisolone or azathioprine, which suppresses the production of antibodies that cause the disease. Thymectomy, or surgical removal of the thymus, can improve symptoms even in patients without a thymoma. And rituximab, which is a monoclonal antibody against B cells, which reduces the antibodies that are produced, is considered where other treatments fail. Finally, let's talk about myasthenic crisis. Myasthenic crisis is a potentially life-threatening complication of myasthenia gravis. It causes an acute worsening of symptoms often triggered by another illness, such as a respiratory tract infection. In myasthenic crisis, respiratory muscle weakness can lead to respiratory failure. Patients may require non-invasive ventilation or mechanical ventilation. Treatment of myasthenic crisis is with intravenous immunoglobulins and plasmapheresis. Chapter 138: Lambert-Eaton myasthenic syndrome. Lambert-Eaton myasthenic syndrome is an autoimmune condition affecting the neuromuscular junction, which is the connection between the motor neurons and the muscles. In some ways, it's similar to myasthenia gravis, however, the symptoms tend to be more insidious and less pronounced than myasthenia gravis. In most cases, it's a paraneoplastic syndrome occurring alongside small cell lung cancer. However, it can occur as a primary autoimmune disorder without the presence of small cell lung cancer. Let's start with the pathophysiology. Lambert-Eaton myasthenic syndrome results from antibodies that are created against voltage-gated calcium channels, and these antibodies are produced in response to small cell lung cancer cells that also express voltage-gated calcium channels. The immune system recognizes the small cell lung cancer and produces antibodies. These antibodies target and damage voltage-gated calcium channels in the presynaptic membrane of the neuromuscular junction. Voltage-gated calcium channels are responsible for assisting in the release of acetylcholine into the synapse of the neuromuscular junction. Acetylcholine travels across the synapse and attaches to receptors on the postsynaptic membrane, and this is what stimulates muscle contraction. When the voltage-gated calcium channels are destroyed, less acetylcholine is released into the synapse, resulting in a weaker signal and reduced muscle contraction. Let's talk about the presentation. The key presenting features are proximal muscle weakness, causing difficulty climbing stairs, standing from a seat, or raising the arms overhead. Autonomic dysfunction, which causes a dry mouth, blurred vision, impotence or erectile dysfunction, and dizziness. And reduced or absent tendon reflexes on examination. The signs and symptoms of Lambert-Eaton myasthenic syndrome improve after periods of muscle contraction, which is the opposite of what is seen in myasthenia gravis. In a patient that's been resting, the reflexes may be absent. However, after the patient has been maximally contracting the muscles, the reflexes may become present on immediately testing after the muscle contraction. Similarly, the muscle strength may improve after the muscles have been used compared to when the muscles are rested. Finally, let's talk about management. It's essential to exclude an underlying malignancy in patients with Lambert-Eaton myasthenic syndrome, specifically small cell lung cancer. Amifampridine is a specialist medication for Lambert-Eaton myasthenic syndrome. Amifampridine works by blocking voltage-gated potassium channels in the presynaptic membrane, and this in turn prolongs the depolarization of the cell membrane and assists the calcium channels in carrying out their action. Other management options include pyridostigmine, which is a cholinesterase inhibitor, immunosuppressants, for example prednisolone or azathioprine, IV immunoglobulins, and plasmapheresis. Chapter 139. Charcot-Marie-Tooth disease. Charcot-Marie-Tooth disease is an inherited disease that affects the peripheral, motor, and sensory neurons. It's also known as hereditary motor and sensory neuropathy. There are various types with different genetic mutations and pathophysiology, causing myelin or axon dysfunction. The majority of mutations are inherited in an autosomal dominant pattern. Symptoms usually start to appear before the age of 10, but they can be delayed until 40 years of age or later. Let's talk about the classic features. There are some classical features of Charcot-Marie-Tooth disease, which include high foot arches, or pes cavus, distal muscle wasting, which causes an appearance which is described as inverted champagne bottle legs, meaning narrow right at the bottom and then thicker higher up. Lower leg weakness, particularly in ankle dorsiflexion, trying to lift the foot up towards the head. This results in foot drop, meaning that the foot flops downwards when lifting the leg. And therefore patients develop what's called a high stepping gait, which is where they have to lift their foot up high to avoid tripping over. Other features include weakness in the hands, reduced tendon reflexes, reduced muscle tone, and peripheral sensory loss, or peripheral neuropathy. Let's talk in more detail about peripheral neuropathy. Peripheral neuropathy refers to reduced sensory and motor function in the peripheral nerves, typically affecting the feet and the hands in a stocking-glove distribution. It's a characteristic feature of Charcot-Marie-Tooth disease. Other causes of peripheral neuropathy can be remembered with the ABCDE mnemonic: A for alcohol, B for B12 deficiency, C for cancer, for example myeloma, and chronic kidney disease, D for diabetes and drugs, for example isoniazid, amiodarone, leflunomide, and cisplatin, and E for every vasculitis. A Tom tip for you: a common OSCE scenario is to examine a patient with peripheral neuropathy. Charcot-Marie-Tooth is a relatively common condition with good signs and stable patients, which makes it popular in OSCEs. Look for the other features of the condition, suggest the diagnosis, and then run through the ABCDE mnemonic to indicate the other possible causes of peripheral neuropathy. Finally, let's talk about management. There's no cure or treatment to prevent Charcot-Marie-Tooth disease from progressing. Management is supportive, with input from various members of the multidisciplinary team. Neurologists and geneticists are there to make a diagnosis. Physiotherapists are useful to help maintain the muscle strength and the joint range of motion. Occupational therapists can help the patient manage their daily activities. Podiatrists can help with foot symptoms and suggest insoles and other orthoses to improve symptoms. Analgesia is used for neuropathic pain, for example amitriptyline, and orthopedic surgeons may be required for severe joint deformities. Chapter 140: Guillain-Barré Syndrome. Guillain-Barré syndrome is an acute paralytic polyneuropathy that affects the peripheral nervous system. It causes acute, symmetrical, ascending weakness and can cause sensory symptoms. It's usually triggered by an infection and is particularly associated with Campylobacter jejuni, cytomegalovirus or CMV, and Epstein-Barr virus or EBV infection. Let's start with the pathophysiology. Guillain-Barré syndrome is thought to occur due to a process called molecular mimicry. The B cells of the immune system create antibodies against the antigens on the triggering pathogen, for example, Campylobacter. These antibodies also match proteins on the peripheral neurons. They may target proteins on the myelin sheath or the nerve axon itself, causing damage to the peripheral neurons and the symptoms. Let's talk about the presentation. Symptoms usually start within 4 weeks of the triggering infection. They can begin in the feet and then ascend upwards. Symptoms typically peak within 2 to 4 weeks. Then there is a recovery period that can last months to years. The characteristic features are symmetrical ascending weakness and reduced reflexes. There may be peripheral loss of sensation or neuropathic pain. It may progress to the cranial nerves and cause facial weakness. Autonomic dysfunction can lead to urinary retention, ileus, or heart arrhythmias. Let's talk about the diagnosis. The diagnosis of Guillain-Barré syndrome is made clinically using the Brighton criteria and is supported by investigations. Investigations to support a diagnosis of Guillain-Barré syndrome include nerve conduction studies, which show reduced signal in the nerves, and lumbar puncture for cerebrospinal fluid analysis. And in the cerebrospinal fluid, there will be raised protein with a normal cell count and glucose. Next, let's talk about management. Management involves supportive care, venous thromboembolism prophylaxis, and pulmonary embolism is a leading cause of death due to the reduced mobility that comes with the muscle weakness. IV immunoglobulins are first line as medical treatment, and plasmapheresis is an alternative to the IV immunoglobulins. Severe cases with respiratory failure may require intubation, ventilation, and admission to the intensive care unit. Finally, let's talk about the prognosis. Recovery can take months to years. Patients can continue regaining function 5 years after the acute illness. Most patients eventually either make a full recovery or are left with only minor symptoms. Some patients are left with a significant disability. The mortality rate is around 5%, mainly due to respiratory or cardiovascular complications. Chapter 141: Neurofibromatosis. Neurofibromatosis is a genetic condition that causes nerve tumors called neuromas to develop throughout the nervous system. These tumors are benign, but they can cause neurological and structural problems. Neurofibromatosis type 1 is more common than neurofibromatosis type 2. This content mainly focuses on type 1. Let's talk about the neurofibromatosis type 1 gene. The type 1 gene is found on chromosome 17. It codes for a protein called neurofibromin, which is a tumor suppressor protein. This means it's a protein that works to suppress tumors. When there's a mutation, the protein doesn't work properly and tumors develop. Mutations in this gene are inherited in an autosomal dominant pattern. Let's go through the features of neurofibromatosis type 1. The diagnostic criteria for neurofibromatosis type 1 are based on the features, and these can be remembered with the crabbing mnemonic. C is for café au lait spots, or milky coffee spots, and these need to be more than 15 millimeters in diameter in adults to be significant. R is for a relative with neurofibromatosis type 1. A is for axillary or inguinal freckling. B is for bony dysplasia, such as bowing of the long bones or sphenoid wing dysplasia. I is for iris hamartomas or leash nodules, which are yellow-brown spots on the iris in the eye. N is for neurofibromas, and G is for glioma of the optic pathway. Neurofibromas may be seen on the skin. They're skin-coloured, raised nodules or papules with a smooth, regular surface. A single skin neurofibroma without other features does not indicate neurofibromatosis. 2 or more standard neurofibromas are significant. A plexiform neurofibroma is a larger, irregular, complex neurofibroma containing multiple cell types. A single plexiform neurofibroma is significant. Next, let's talk about management. Diagnosis is based on the diagnostic criteria. Genetic testing can be helpful. There is no treatment for the underlying disease process, and management involves monitoring, managing symptoms, and treating complications. Let's go through the complications. The complications of neurofibromatosis type 1 are migraines, epilepsy, renal artery stenosis, which causes hypertension or high blood pressure, learning disability, behavioral problems, for example ADHD, scoliosis of the spine, vision loss secondary to optic nerve gliomas, malignant peripheral nerve sheath tumours, gastrointestinal stromal tumours, which are a type of sarcoma, brain tumours, spinal cord tumours with associated neurological symptoms, for example paraplegia, and an increased risk of cancer, for example breast cancer and leukemia. A Tom tip for you: the 2 unique complications worth remembering for neurofibromatosis type 1 are malignant peripheral nerve sheath tumours and gastrointestinal stromal tumours. Finally, let's talk about neurofibromatosis type 2. The neurofibromatosis type 2 gene is found on chromosome 22. It codes for a protein called myelin, which is a tumor suppressor protein important in Schwann cells. Schwann cells provide the myelin sheath that surrounds neurons of the peripheral nervous system. Mutations in this gene lead to schwannomas, which are benign tumors of the Schwann cells. It's inherited in an autosomal dominant pattern. Neurofibromatosis type 2 is particularly associated with acoustic neuromas, which are tumors of the auditory nerve that innervates the inner ear. Surgery can be used to resect the tumors, although there is a significant risk of permanent nerve damage. A Tom tip for you: an exam patient with bilateral acoustic neuromas almost certainly has neurofibromatosis type 2. Chapter 142: Tuberous sclerosis. Tuberous sclerosis is an autosomal dominant genetic condition that affects multiple systems. The characteristic feature is the development of hamartomas, which are benign tissue growths. Hamartomas cause problems based on the location of the lesion. They commonly affect the skin, brain, lungs, heart, kidneys, and eyes. Tuberous sclerosis is caused by mutations in either the TSC1 gene on chromosome 9, which codes for hamartin, or the TSC2 gene on chromosome 16, which codes for tuberin. Hamartin and tuberin interact with each other to control the size and growth of cells. Abnormalities in one of these proteins leads to abnormal cell size and growth. Let's talk about the features. The skin features of tuberous sclerosis include ash leaf spots, which are depigmented areas of skin shaped like an ash leaf, shagreen patches, which are thickened, dimpled, pigmented patches of skin, angiofibromas, which are small skin-colored or pigmented papules that occur over the nose and the cheeks, ungual fibromas, which are circular painless lumps that grow slowly from the nail bed and displace the nail, café au lait spots, which are light brown, coffee and milk coloured, flat, pigmented lesions on the skin, and poliosis, which is an isolated patch of white hair on the head, eyebrows, eyelashes, or beard. Neurological features include epilepsy, learning disability, and brain tumours. Other features include rhabdomyoma in the heart, angiomyolipoma in the kidneys, lymphangioliomyomatosis in the lungs, subependymal giant cell astrocytoma in the brain, and retinal hamartoma in the eyes. Finally, let's talk about management. There's no treatment for the underlying gene defect that causes tuberous sclerosis. Management is supportive and involves monitoring and treating complications, particularly epilepsy. In specific circumstances, mTOR inhibitors, for example, everolimus or sirolimus, may be used to suppress the growth of brain, lung, or kidney tumours. Chapter 143. Headaches. Headaches are a very common presentation, and they have a large number of causes, including tension headaches, migraines, cluster headaches, secondary headaches, sinusitis, giant cell arteritis, glaucoma, intracranial hemorrhage, venous sinus thrombosis, subarachnoid hemorrhage, medication overuse headache, hormonal headache, cervical spondylosis, carbon monoxide poisoning, trigeminal neuralgia, raised intracranial pressure, brain tumours, meningitis, encephalitis, brain abscess, and preeclampsia in pregnancy. Let's start by going through the red flags. The key red flags associated with a headache, which indicate a possible serious underlying cause, include fever, photophobia, or neck stiffness, which could indicate meningitis, encephalitis, or a brain abscess, new neurological symptoms, which could indicate a hemorrhage or brain tumour, visual disturbance, which may indicate giant cell arteritis, glaucoma, or tumours, sudden onset occipital headache at the back of the head could indicate a subarachnoid hemorrhage. A headache that's worse on coughing or straining can indicate raised intracranial pressure. Postural symptoms, where the headache is worse on standing, lying, or bending over, could indicate raised intracranial pressure. Vomiting can indicate raised intracranial pressure or carbon monoxide poisoning. A history of trauma can indicate intracranial hemorrhage. A history of cancer may indicate brain metastases. And in a pregnant patient, a headache can indicate preeclampsia. Fundoscopy examination, having a look at the back of the eye for papilledema, is required in patients presenting with a headache. The presence of papilledema suggests raised intracranial pressure, which may be due to a brain tumour, benign intracranial hypertension, or an intracranial bleed. A Tom tip for you, asking specifically about red flags during a history demonstrates that you're thinking about serious causes. This will score you extra points in OSCE exams and help you document well when you're seeing patients. Let's talk about tension headaches. Tension headaches are very common. They typically cause a mild ache or pressure in a band-like pattern around the head. They develop and resolve gradually, and they do not cause visual changes. Tension headaches may be associated with stress, depression, alcohol use, skipping meals, and dehydration. Management of tension headaches is with reassurance and simple analgesia, such as ibuprofen or paracetamol. Amitriptyline is generally first line for chronic or frequent tension headaches. Next, let's talk about secondary headaches. Secondary headaches give a similar presentation to a tension headache, but they have a clear cause, such as infections, for example, a viral upper respiratory tract infection, obstructive sleep apnea, preeclampsia, head injury, or carbon monoxide poisoning. Next, let's talk about sinusitis. Sinusitis refers to inflammation of the paranasal sinuses in the face. It typically causes pain and pressure following a recent viral upper respiratory tract infection. There may be tenderness and swelling on palpation of the affected areas. Most cases of sinusitis are caused by a viral infection, and they resolve within 2 to 3 weeks. Prolonged cases, lasting more than 10 days, may be treated with a steroid nasal spray, for example mometasone, or delayed antibiotics, and phenoxymethylpenicillin or penicillin V is the first-line antibiotic. Next, let's talk about medication overuse headache. Medication overuse headache, also called analgesic headache, is a headache caused by frequent analgesia use. It gives similar non-specific features to a tension headache. Withdrawal of analgesia is important in treating the headache, although this can be challenging in patients with long-term pain. Next, let's talk about hormonal headache. Hormonal headaches are related to low estrogen in women. They have similar features to migraines, with a unilateral, pulsatile headache associated with nausea. They're sometimes called menstrual headaches. They may occur 2 days before and during the first 3 days of the menstrual period, in the perimenopausal period, or in early pregnancy. It's worth noting that headaches in the second half of pregnancy should prompt investigations for preeclampsia. Triptans and non-steroidal anti-inflammatory drugs, or NSAIDs, such as mefenamic acid, are treatment options for hormonal headache, except during pregnancy. Next, let's talk about cervical spondylosis. Cervical spondylosis is caused by degenerative changes in the cervical spine. It causes neck pain, usually made worse by movement, and it often presents with headaches at the back of the head and the back of the neck. Finally, let's talk about trigeminal neuralgia. Trigeminal neuralgia causes intense facial pain in the distribution of the trigeminal nerve. The trigeminal nerve has 3 branches: the ophthalmic, or V1, the maxillary, or V2, and the mandibular, or V3 branches. Trigeminal neuralgia can affect any combination of the branches. Over 90% of cases are unilateral, affecting only one side of the face. It's more common in patients with multiple sclerosis. The pain comes on suddenly and lasts seconds to hours. It may be described as an electricity-like shooting, stabbing, or burning pain. It may be triggered by touch, talking, eating, shaving, or cold. The attacks of trigeminal neuralgia may worsen over time. The NICE Clinical Knowledge Summaries from 2022 recommend carbamazepine first line for trigeminal neuralgia. Various surgical interventions are possible where the symptoms persist. Chapter 144: Migraines. Migraine is a complex neurological condition causing episodes or attacks of headache and associated symptoms. Migraine is very common. It tends to affect women more often than men, and it's most common in teenagers and young adults. Migraine can be categorized into 4 main types: migraine without aura, migraine with aura, silent migraine, which is a migraine with aura but without a headache, and hemiplegic migraine. The pathophysiology of migraine has been studied for decades. Various mechanisms and theories have been developed. It's likely a combination of structural, functional, chemical, vascular, and inflammatory factors. Let's talk about the typical symptoms. There are 5 stages of a typical migraine: the premonitory or prodromal stage, and this can be present for several days before the onset of the headache; the aura stage, which can last up to 60 minutes, the headache stage, which lasts 4 to 72 hours, the resolution stage, which is where the headache either fades away or is relieved abruptly by vomiting or sleeping, and the postdromal or recovery phase. These stages vary between patients. Some patients may only experience 1 or 2 of the stages. The prodromal stage may involve days of subtle symptoms such as yawning, fatigue, or mood changes before the headache starts. Migraine headaches last 4 to 72 hours. Typical features are that they're unilateral, meaning on one side of the head, but they can be bilateral. They're moderate to severe in intensity. They have a pounding or throbbing nature. There's associated photophobia, which is discomfort with lights, phonophobia, which is discomfort with loud noises, and osmophobia, which is discomfort with strong smells, aura, which are visual changes, and nausea and vomiting. Let's talk in more detail about aura. Aura can affect vision, sensation, or language. Visual symptoms are the most common, and these may be sparks in the vision, blurred vision, lines across the vision, or loss of visual fields, for example, a scotoma, with an enlarged blind spot in the visual field. Sensation changes caused by aura may include tingling or numbness. Language symptoms include dysphasia, which is difficulty speaking. Next, let's talk about hemiplegic migraine. Hemiplegic migraine involves hemiplegia, which is unilateral limb weakness. Other symptoms may include ataxia, which is a loss of coordination, and impaired consciousness. Familial hemiplegic migraine is an autosomal dominant genetic condition characterized by hemiplegic migraines that run in families. However, hemiplegic migraines also occur without any genetic link or family history. Hemiplegic migraines can mimic a stroke or a TIA. It's essential to exclude a stroke with a sudden onset of hemiplegia. Let's talk about migraine triggers. Migraine triggers vary between patients, and they may include stress, bright lights, strong smells, certain foods, for example chocolate, cheese, or caffeine, dehydration, menstruation in women, disrupted sleep, and trauma. Next, let's talk about the acute management of migraines. Patients may develop strategies for managing the symptoms themselves, often retreating to a dark, quiet room and sleeping. Medical options for an acute attack of migraine are non-steroidal anti-inflammatory drugs, for example ibuprofen or naproxen, paracetamol, triptans, for example sumatriptan, and antiemetics if vomiting occurs, for example metoclopramide or prochlorperazine. Opiates, such as codeine or morphine, are not used to treat migraines, and they may make the condition worse. Let's talk in more detail about triptans. Triptans are used to abort migraines when they start to develop. They are 5-HT receptor agonists. They bind to and stimulate serotonin receptors, specifically 5-HT1B and 5-HT1D. They have various mechanisms of action, which include cranial vasoconstriction, meaning they constrict the blood vessels in and around the brain, inhibiting the transmission of pain signals, and inhibiting the release of inflammatory neuropeptides. Triptans, for example sumatriptan, are taken as soon as a migraine attack starts. They should halt the attack in its tracks. If the migraine attack resolves and then reoccurs, another dose can be taken. If the triptan does not work the first time, a second dose should not be taken for the same attack. The main contraindications to triptans relate to risks associated with vasoconstriction, for example hypertension or high blood pressure, coronary artery disease in the heart, or a previous stroke, TIA, or myocardial infarction. Next, let's talk about migraine prophylaxis. A headache diary can help identify triggers and assess the response to treatment. Avoiding triggers can be helpful. The usual prophylactic medications to reduce the frequency and severity of migraine attacks are propranolol, which is a non-selective beta blocker, amitriptyline, which is a tricyclic antidepressant, and topiramate, which is an antiepileptic medication. With topiramate, it's worth noting it's highly teratogenic, meaning that it's harmful in pregnancy and very effective contraception is needed. More specialist prophylactic options include pizotifen, candesartan, sodium valproate, and monoclonal antibodies, for example erenumab and fremanezumab. Other options that are mentioned in the NICE clinical knowledge summaries updated in 2022 include cognitive behavioral therapy, mindfulness and meditation, acupuncture, and vitamin B2 or riboflavin, but this should be avoided in pregnancy. Prophylactic triptans, for example frovatriptan and zolmitriptan, are an option for menstrual migraines. The symptoms of menstrual migraines tend to occur for the 2 days before and the first 3 days of the menstrual period. Regular triptans may be taken during this time to prevent them. Migraines in general tend to become less frequent and severe or stop altogether as the patient gets older, particularly after the menopause. Migraines are associated with a slightly increased risk of stroke, particularly when they're associated with aura. The risk is further increased with the combined contraceptive pill. Therefore, migraine with aura is a contraindication to the combined pill. Chapter 145. Cluster headaches. Cluster headaches are severe and unbearable unilateral headaches, usually centered around the eye. They are sometimes called suicide headaches due to their severity. They're called cluster headaches because they come in clusters of attacks and then they disappear for extended periods. For example, a patient may suffer 3 to 4 headaches a day for weeks or months, followed by a pain-free period that lasts several years. Headaches last between 15 minutes and 3 hours. The typical patient is a 30 to 50-year-old male smoker. They may have triggers such as alcohol, strong smells, or exercise. Let's go through the symptoms. The symptoms are usually unilateral, including pain centered around the eye, a red, swollen, and watering eye, pupil constriction or miosis, eyelid drooping or ptosis, nasal discharge, and facial sweating. Let's go through the management. Treatment options during acute attacks of cluster headaches are triptans, for example subcutaneous or intranasal sumatriptan, and high-flow 100% oxygen, which may be kept at home ready for attacks. Verapamil, which is a calcium channel blocker, is the first line for prophylaxis to prevent attacks. Other options for prophylaxis are occipital nerve block, prednisolone, for example a short course of prednisolone to break the cycle during clusters, and lithium. Chapter 146. Open-angle glaucoma. Glaucoma refers to the optic nerve damage that's caused by a rise in intraocular pressure, the pressure inside the eye. Raised intraocular pressure is caused by a blockage in aqueous humor trying to drain away from the eye. There are two types of glaucoma, open-angle glaucoma and acute angle closure glaucoma. Let's start with the basic anatomy and physiology. The anterior chamber, which is between the cornea and the iris, and the posterior chamber, which is between the lens and the iris, are filled with aqueous humor. Aqueous humor supplies nutrients to the cornea. It's produced by the ciliary body and it flows from the posterior chamber around the iris to the anterior chamber of the eye. It drains through the trabecular meshwork into the canal of Schlemm at the angle between the cornea and the iris. From there it enters the general circulation. A normal intraocular pressure is between 10 and 21 millimeters of mercury, and this is created by the resistance to flow through the trabecular meshwork as the aqueous humor drains out. An increased resistance to flow through the trabecular meshwork will result in an increased intraocular pressure. Let's talk about the pathophysiology. With open-angle glaucoma, there is a gradual increase in resistance to flow through the trabecular meshwork. The pressure slowly builds within the eye. Raised intraocular pressure causes cupping of the optic disc. In the center of the optic disc is an indent that's called the optic cup. The optic cup is usually less than 50% of the size of the optic disc. Raised intraocular pressure causes this indent to become wider and deeper, and this is described as cupping. A cup-disc ratio greater than 0.5 is abnormal. Let's talk about the risk factors. The risk factors for open-angle glaucoma include increased age, family history, black ethnic origin, and myopia, or nearsightedness. Next, let's go through the presentation. The rise in intraocular pressure may be asymptomatic for a long time and diagnosed by routine eye testing. Glaucoma affects the peripheral vision first, resulting in a gradual onset of peripheral vision loss, causing tunnel vision. It can also cause fluctuating pain in the eye, headaches, blurred vision, and halos seen around lights, particularly at nighttime. Next, let's talk about measuring the intraocular pressure. Non-contact tonometry is used by opticians for estimating the intraocular pressure. This involves shooting a puff of air at the cornea and measuring the response. It's less accurate, but it gives an estimate for general screening purposes. Goldmann applanation tonometry is the gold standard way to measure the intraocular pressure. This involves a device mounted onto a slit lamp that makes contact with the cornea and applies various pressures measuring the response. Next, let's talk about making the diagnosis. The diagnosis of open-angle glaucoma is based on Goldmann applanation tonometry to measure the intraocular pressure, slit lamp assessment for the cup-disc ratio and the optic nerve health, visual field assessment to look for peripheral vision loss, gonioscopy to assess the angle between the iris and the cornea, and central corneal thickness assessment. Finally, let's talk about management. Treatment is typically started at an intraocular pressure of 24 millimeters of mercury or above. 360-degree selective laser trabeculoplasty is recommended in the NICE guidelines updated in 2022 for all patients that need treatment for open-angle glaucoma. During the procedure, a laser is directed at the trabecular meshwork, and this improves drainage. It may delay or prevent the need for eye drops. A second procedure may be necessary at a later date. Prostaglandin analog eye drops, for example latanoprost, are the first-line medical treatment. These increase the uveoscleral outflow. Notable side effects are eyelash growth, eyelid pigmentation, and iris pigmentation, particularly browning of the iris. Other eye drop options for treating open-angle glaucoma include beta blockers, for example timolol, which reduce the production of aqueous humor, carbonic anhydrase inhibitors, for example dorzolamide, which reduce the production of aqueous humor, and sympathomimetics, for example brimonidine, which reduce the production of aqueous humor and increase the uveoscleral outflow. Trabeculectomy surgery is required where other treatments are ineffective. This involves creating a new channel from the anterior chamber through the sclera to a location under the conjunctiva, causing a bleb on the conjunctiva. Aqueous humor can flow through this new channel through the sclera to under the conjunctiva, and from here it's reabsorbed into the general circulation. Chapter 147. Acute angle closure glaucoma. Acute angle closure glaucoma occurs when the iris bulges forward and seals off the trabecular meshwork from the anterior chamber of the eye, and this prevents the aqueous humor from draining and causes a continual increase in the intraocular pressure. Increased pressure in the posterior chamber pushes the iris forward and further exacerbates the angle closure. Acute angle closure glaucoma is an emergency and requires rapid treatment to prevent permanent vision loss. Let's go through the risk factors. The risk factors for acute angle closure glaucoma include increasing age, a family history, being female, and females are 4 times more likely to be affected than males, coming from a Chinese and East Asian ethnic origin, and having a shallow anterior chamber to the eye. A Tom tip for you, note the difference in risk factors between angle closure and open angle glaucoma, particularly in ethnic origin. Black people are affected more often by open angle glaucoma, while angle closure glaucoma is rare in this group and more common in East Asians. If an exam question mentions ethnic origin, it's probably relevant as a risk factor and gives a clue about the diagnosis. Certain medications can precipitate acute angle closure glaucoma, and these include adrenergic medications, such as noradrenaline, anticholinergic medications, for example oxybutynin and solifenacin, and tricyclic antidepressants, for example amitriptyline, which have anticholinergic side effects. Next, let's talk about the presentation. A typical patient with acute angle closure glaucoma presents appearing generally unwell, with a short history of a severely painful red eye, blurred vision, halos appearing around lights, and associated headache, nausea, and vomiting. Signs on examination include a red eye, a hazy cornea, decreased visual acuity, a mid-dilated pupil, a fixed size to the pupil, and a hard eyeball on gentle palpation. Let's talk about the initial management. Acute angle closure glaucoma requires immediate admission. Measures that can be taken while waiting for an ambulance include lying the patient on their back without a pillow, pilocarpine eye drops, 2% for blue eyes and 4% for brown eyes, acetazolamide, 500 mg orally, and analgesia and an antiemetic if required. pilocarpine acts on the muscarinic receptors in the sphincter muscles of the iris and it causes pupil constriction. It's a miotic agent. It also causes ciliary muscle contraction. These two effects open the pathway for the flow of aqueous humor from the ciliary body around the iris and into the trabecular meshwork. Acetazolamide is a carbonic anhydrase inhibitor that reduces the production of aqueous humor. Finally, let's talk about the management in secondary care. Specialist medical options for acute angle closure glaucoma include pilocarpine eye drops, acetazolamide, either oral or intravenous, hyperosmotic agents, for example intravenous mannitol, which increase the osmotic gradient between the blood and the eye, timolol, which is a beta blocker that reduces the production of aqueous humor, dorzolamide, which is a carbonic anhydrase inhibitor that reduces the production of aqueous humor, and brimonidine, which is a sympathomimetic, meaning it stimulates the sympathetic nervous system that reduces aqueous humor production and increases the uveoscleral outflow. Laser iridotomy is usually required as the definitive surgical treatment. This involves making a hole in the iris using a laser, which allows the aqueous humor to flow directly from the posterior chamber to the anterior chamber. This relieves the pressure pushing the iris forward against the cornea and opens the pathway for the aqueous humor to drain. Chapter 148: Age-related macular degeneration. Age-related macular degeneration, or AMD, is a progressive condition affecting the macula in the eye. It's the most common cause of blindness in the UK. It's often unilateral, but it may be bilateral. There are two types: wet age-related macular degeneration, which is also called neovascular AMD, accounts for about 10% of cases, and dry AMD, also called non-neovascular, accounts for about 90% of cases. The macula is found in the center of the retina at the back of the eye. It generates high-definition color vision in the central visual field. The macula has 4 layers. The choroid layer at the base contains the blood vessels that supply the macula, Bruch's membrane, the retinal pigment epithelium, and the photoreceptors towards the surface. Drusen are an important finding in age-related macular degeneration. Drusen are yellowish deposits of proteins and lipids between the retinal pigment epithelium and Bruch's membrane. A few small drusen can be normal in older patients. Frequent and larger drusen can be an early sign of macular degeneration. Other features that are common to wet and dry age-related macular degeneration are atrophy of the retinal pigment epithelium layer and degeneration of the photoreceptors. In wet AMD, new vessels grow from the choroid layer into the retina, and this is called neovascularization. These vessels can leak fluid or blood, causing edema and vision loss. The development of new vessels is stimulated by vascular endothelial growth factor, or VEGF, which is the target of medications that are used to treat wet AMD. Let's talk about the risk factors. The risk factors for age-related macular degeneration are being older in age, smoking, family history, cardiovascular disease, for example hypertension, obesity, and a poor diet low in vitamins and high in fat. Next, let's talk about the presentation. The visual changes associated with age-related macular degeneration tend to be unilateral, affecting only one eye, with a gradual loss of the central vision, reduced visual acuity, and crooked or wavy appearance to straight lines, and this is called metamorphopsia. Patients often present with a gradually worsening ability to read small text. Wet AMD presents more acutely or more rapidly than dry AMD. Vision loss can develop within days and progress to complete blindness within 2 to 3 years. Wet AMD often progresses to bilateral disease. A Tom tip for you: glaucoma is associated with peripheral vision loss and halos around lights. Age-related macular degeneration is associated with central vision loss and a wavy appearance to straight lines. Cataracts causes a generalized reduction in visual acuity and starbursts around lights. These key features can help you tell them apart in exams. Next, let's talk about examination. The key findings of macular degeneration on examination are reduced visual acuity when using a Snellen chart, a scotoma, which is an enlarged central area of vision loss. The Amsler grid test can be used to assess for the distortion of straight lines, which is seen in macular degeneration, and drusen may be seen on fundoscopy examination. Slit lamp examination gives a detailed view of the retina and the macula. Optical coherence tomography, or OCT, gives a cross-sectional view of the layers of the retina, and this is used for diagnosing and monitoring age-related macular degeneration. Fluorescein angiography involves giving a fluorescein contrast and photographing the retina to assess the blood supply, and this shows edema and neovascularization in wet AMD. Finally, let's talk about management. Patients with suspected age-related macular degeneration require specialist ophthalmology assessment and management. There's no specific treatment for dry AMD. Management involves monitoring and reducing the risk of progression by avoiding smoking, controlling the blood pressure, and there's some evidence that vitamin supplementation can slow the progression. Anti-VEGF medications are used to treat wet AMD, but not dry AMD. Vascular endothelial growth factor, or VEGF, stimulates the development of new blood vessels in the retina. Anti-VEGF medications, for example ranibizumab, aflibercept, and bevacizumab, block VEGF and slow the development of new vessels. These medications are injected directly into the vitreous chamber of the eye, and this is called intravitreal injections, usually around once a month depending on the protocol. Chapter 149: Diabetic retinopathy. Diabetic retinopathy involves damage to the retinal blood vessels due to prolonged high blood sugar levels in diabetes. Let's start with the pathophysiology. Hyperglycemia, which is a high blood glucose level, damages the small vessels in the retina at the back of the eye, particularly the endothelial cells of these blood vessels. Increased vascular permeability leads to leaking blood vessels, blot hemorrhages, and hard exudates on the retina. Hard exudates are yellow-white deposits of lipids and proteins on the retina. Damage to the blood vessel walls leads to microaneurysms and venous beading. Microaneurysms are small bulges in the blood vessel walls. Venous beading is where the walls of the veins of the retina are no longer straight and parallel, and they look more like a string of beads or a string of sausages. Damage to nerve fibers in the retina causes fluffy white patches called cotton wool spots. Intraretinal microvascular abnormalities, or IMRA, refers to dilated and tortuous capillaries on the retina. These can act as a shunt between the arterial and the venous vessels in the retina, meaning that blood flows directly from the arterial to the venous vessels. Neovascularization involves the release of growth factors which stimulates new blood vessel development. Let's go through the grading. Diabetic retinopathy is graded based on the findings on fundoscopy examination. Background diabetic retinopathy involves microaneurysms, retinal hemorrhages, hard exudates, and cotton wool spots. Pre-proliferative diabetic retinopathy involves venous beading, multiple blot hemorrhages, and intraretinal microvascular abnormality, or IMRA. And proliferative diabetic retinopathy involves neovascularization and vitreous hemorrhage. Diabetic maculopathy also exists separately and involves exudates within the macula and macular edema. A Tom tip for you, the main distinction is between non-proliferative, which includes background and pre-proliferative, and proliferative diabetic retinopathy. The key feature of proliferative diabetic retinopathy is the development of new blood vessels, or neovascularization. Let's go through the complications. The complications of diabetic retinopathy are vision loss, retinal detachment, vitreous hemorrhage, or bleeding into the vitreous humor, rubeosis iridis, which is new blood vessel formation in the iris, which can lead to neovascular glaucoma, optic neuropathy, and cataracts. Finally, let's talk about management. Non-proliferative diabetic retinopathy requires close monitoring and careful diabetes control. Treatment options for proliferative diabetic retinopathy are pan-retinal photocoagulation, which is laser treatment to suppress new blood vessel formation, anti-VEGF medications by intravitreal injection, and surgery, for example vitrectomy, which may be required in severe disease. An intravitreal implant containing dexamethasone is an option for macular edema. Chapter 150. Hypertensive retinopathy. Hypertensive retinopathy involves damage to the small blood vessels in the retina resulting from high blood pressure. The changes can happen slowly with chronic hypertension over a long period of time, or they can happen quickly in response to malignant hypertension. Let's go through the features. Silver wiring, or copper wiring, is where the walls of the arterioles become thickened and sclerosed and they reflect more light on examination. This makes them look like silver or copper wires. Arteriovenous nipping, or AV nipping, is where the arterioles cause compression of the veins where they cross due to sclerosis and hardening of the arterioles. Cotton wool spots are caused by ischemia and infarction in the retina, causing damage to the nerve fibers. Hard exudates are caused by damaged blood vessels leaking lipids onto the retina. Retinal hemorrhages are caused by damaged blood vessels rupturing and releasing blood into the retina. Dot and blot hemorrhages occur deeper in the retina in the inner nuclear layer or the outer plexiform layer. Flame hemorrhages occur in the nerve fiber layer. And finally, papilledema is caused by ischemia in the optic nerve, resulting in optic nerve swelling or edema. Let's talk about the Keith-Wagner classification. The Keith-Wagner classification is used to classify hypertensive retinopathy. Stage 1 involves mild narrowing of the arterioles. Stage 2 involves focal constriction of blood vessels and AV nipping. Stage 3 involves cotton wool patches, exudates, and hemorrhages. And stage 4 involves papilledema. Finally, let's talk about management. Management is focused on controlling the blood pressure and managing the risk factors, for example, smoking and the blood lipid levels. Chapter 151. Cataracts. Cataracts describe when the lens of the eye becomes progressively opaque, which reduces the light entering the eye and reduces the visual acuity. Essentially, the lens of the eye becomes cloudy, which reduces the light and the information that's entering the eye and reduces how clear the vision is. The role of the lens is to focus light onto the retina. The retina is what senses information coming into the eye and sends a signal to the brain. The lens is held in place by suspensory ligaments that are attached to the ciliary body. The ciliary body contracts and relaxes to change the shape of the lens. When the ciliary body contracts, it releases tension on the suspensory ligaments and the lens thickens. When the ciliary body relaxes, the suspensory ligaments tension and the lens narrows. The lens has no blood supply and it's nourished by the aqueous humor. Most cataracts take years to develop and they're associated with older age. Congenital cataracts occur before birth. The red reflex is tested during the neonatal examination to screen for congenital cataracts in babies that are born with cataracts. Let's go through the risk factors. The risk factors for cataracts are increasing age, smoking, alcohol, diabetes, the use of steroids, and hypocalcemia, or a low calcium level. Let's talk about the presentation. The symptoms of cataracts are usually asymmetrical, as both eyes are affected separately. It presents with slow reduction in visual acuity, progressive blurring of the vision, colors can become more faded, brown, or yellow, and starbursts can appear around lights, particularly at nighttime. A loss of the red reflex is a key examination finding. The lens can appear grey or white when using an ophthalmoscope, even from a distance. And this can be seen on photographs when using a flash, where normally you would see red pupils, the pupil may appear grey or white. Next, let's talk about management. No intervention may be necessary if the symptoms are manageable. Cataract surgery involves drilling and breaking the lens, removing the pieces, and implanting an artificial lens. It can be performed as a day case under a local anesthetic and generally gives good results. Cataracts can prevent the detection of other pathology in the eye, such as macular degeneration or diabetic retinopathy, which can become apparent after surgery. Therefore, the patient may still have reduced visual acuity after the cataract is treated. Finally, let's talk about endophthalmitis. Endophthalmitis describes inflammation of the inner contents of the eye, usually caused by infections, and this is a rare but serious complication of cataract surgery that can lead to vision loss. Endophthalmitis is treated with intravitreal antibiotics, which are injected directly into the eye. Chapter 152. Pupil Disorders. The pupil is formed by a hole in the center of the iris. Many conditions can cause abnormally shaped and sized pupils. Let's start by talking about the pupil size. The circular muscles in the iris are responsible for pupil constriction, making the pupil smaller. They are stimulated by the parasympathetic nervous system using acetylcholine as a neurotransmitter. The parasympathetic fibers travel along the oculomotor nerve or cranial nerve 3. The dilator muscles in the iris are responsible for pupil dilation, making the pupil bigger. The dilator muscles are arranged like spokes on a bicycle wheel, traveling straight from the inside to the outside of the iris. They're stimulated by the sympathetic nervous system using adrenaline as a neurotransmitter. Therefore, the parasympathetic nervous system causes pupil constriction and the sympathetic nervous system causes pupil dilation. A Tom tip for you, I picture a parrot sitting on the arch of the circular muscles to remember that the parasympathetic nervous system controls pupil constriction. I think to myself, parrot sympathetic. Next, let's talk about the causes of an abnormal pupil shape. Trauma to the sphincter muscles in the iris can cause an irregular pupil shape, for example, trauma during cataract surgery. Anterior uveitis can cause adhesions or scar tissue in the iris, and this can cause an irregular pupil shape. Acute angle closure glaucoma can cause ischemic damage to the muscles of the iris and an abnormal pupil shape, typically a vertical oval shape. Rubiosis iridis, or neovascularization in the iris with new blood vessels developing inside the iris, can distort the shape of the iris and change the pupil shape. This is usually associated with poorly controlled diabetes and diabetic retinopathy. Coloboma is a congenital malformation that can cause a hole in the iris and an abnormal pupil shape. And finally, tadpole pupil involves muscle spasm in part of the dilator muscle of the iris, causing a misshapen pupil. It's a temporary condition that may be associated with migraines and Horner's syndrome. Let's go through the causes of mydriasis, or a dilated pupil. The causes of mydriasis, or a dilated pupil, are congenital, stimulants, for example, cocaine, anticholinergic drugs, for example, oxybutynin, trauma to the eye, third nerve palsy, Holmes-AD syndrome, raised intracranial pressure, and acute angle closure glaucoma. Next, let's go through the causes of miosis, or a constricted pupil. The causes of miosis, or a constricted pupil, are Horner syndrome, cluster headaches, Argyll-Robertson pupil in neurosyphilis, opiates, nicotine use, and pilocarpine. Next, let's talk about third nerve palsy. A palsy of the third cranial nerve, which is the oculomotor nerve, causes ptosis, or drooping of the upper eyelid, a dilated, non-reactive pupil, and divergent strabismus, or squint in the affected eye, with a down and out position of the affected eye. The third cranial nerve, or the oculomotor nerve, supplies all the extraocular muscles, which are the muscles that control eye movement, except for the lateral rectus and the superior oblique. Therefore, when the oculomotor nerve stops working, most of the extraocular muscles stop working, and the lateral rectus and the superior oblique, which are still working, pull the eye downwards and outwards. The oculomotor nerve also supplies the levator palpebrae superioris, which is responsible for lifting the upper eyelid. Therefore, a third cranial nerve palsy results in ptosis, or drooping of the upper eyelid. The oculomotor nerve also carries parasympathetic fibers that innervate the circular muscles of the iris. Therefore, third nerve palsy causes a dilated, non-reactive pupil, as the circular muscles in the iris can't contract and cause the pupil to constrict. Third nerve palsy can be idiopathic, without a clear cause. A third nerve palsy that does not affect the pupil, which is described as sparing of the pupil, suggests a microvascular cause, as the parasympathetic fibers have been spared, which is why the pupil still works. This may be due to diabetes, hypertension, or ischemia. A full third nerve palsy is caused by compression of the nerve, including compression of the parasympathetic fibers. This may be due to a tumor, trauma, cavernous sinus thrombosis, an aneurysm of the posterior communicating artery, or raised intracranial pressure. The oculomotor nerve travels directly from the brainstem to the eye in a straight line. It travels through the cavernous sinus and close to the posterior communicating artery. Therefore, cavernous sinus thrombosis or a posterior communicating artery aneurysm can cause nerve compression and a third nerve palsy. Next, let's talk about Horner syndrome. Horner syndrome involves a triad of ptosis, or drooping of the upper eyelid, miosis, which is a constricted pupil, and anhidrosis, which is a loss of sweating. There may also be enophthalmos, which is a sunken eye. The light and accommodation reflexes are not affected in Horner syndrome. Horner syndrome is caused by damage to the sympathetic nervous system that supplies the face. The sympathetic nerves arise from the spinal cord in the chest. These are the preganglionic nerves. They enter the sympathetic ganglion at the base of the neck and exit as postganglionic nerves. The postganglionic nerves travel to the head alongside the internal carotid artery. A lesion to the sympathetic nervous system anywhere along this pathway can cause Horner syndrome. The location of the lesion causing Horner syndrome can be determined by the anhidrosis or loss of sweating. Central lesions occurring before the nerves exit the spinal cord cause anhidrosis of the arm, trunk, and face. Preganglionic lesions cause anhidrosis only of the face, and postganglionic lesions do not cause anhidrosis. The causes of Horner syndrome can be remembered with the 4 S's, 4 T's, and 4 C's mnemonic. S for central causes, T for torso or preganglionic causes, and C for cervical or postganglionic causes. Central causes are the 4 S's: stroke, multiple sclerosis, swellings, meaning tumours, and syringomyelia, which is a cyst in the spinal cord. Preganglionic causes are remembered with the 4 T's: tumour, specifically a Pancoast tumour at the pulmonary apex or the top of the lung; trauma, thyroidectomy or removal of the thyroid gland; and top rib, referring to a cervical rib that grows above the first rib and the clavicle, causing compression of the sympathetic nerves. And postganglionic causes can be remembered with the 4 C's: carotid aneurysm, carotid artery dissection, cavernous sinus thrombosis, and cluster headaches. Congenital Horner syndrome is associated with heterochromia, which is a difference in iris color on the affected side. Cocaine eye drops can be used to test for Horner syndrome. Cocaine acts on the eye to stop noradrenaline reuptake at the neuromuscular junction. This causes a normal eye to dilate as noradrenaline stimulates the dilator muscles of the iris. In Horner syndrome, the nerves are not releasing noradrenaline, so blocking reuptake makes no difference and there's no pupil reaction. Alternatively, low-dose adrenaline eye drops, 0.1%, will dilate the pupil in Horner syndrome, but not cause any change to a normal pupil. Next, let's talk about Holmes AD pupil. A Holmes AD pupil is caused by damage to the postganglionic parasympathetic fibers. The cause is unknown. A Holmes AD pupil is dilated, sluggish to react to light, Responsive to accommodation, meaning that the pupil constricts well when shifting focus from a far to a near object. And slow to dilate following constriction. This is described as a tonic pupil. Holmes-AD syndrome features a Holmes-AD pupil with associated absent ankle and knee reflexes. Finally, let's talk about Argyll-Robertson pupil. An Argyll-Robertson pupil is a specific finding in neurosyphilis. It's a constricted pupil that accommodates when focusing on a near object but does not react to light. The accommodation reflex is intact, but the light reflex is absent. Argyll-Robertson pupils are often irregularly shaped. It's commonly called a prostitute's pupil due to its relation to neurosyphilis and because it accommodates but does not react. Chapter 153 Eyelid Disorders. Let's start by talking about blepharitis. Blepharitis refers to inflammation of the eyelid margins, of the edge of the eyelids. It causes a gritty, itchy, dry sensation in the eyes. It can be associated with dysfunction of the meibomian glands, which are responsible for secreting meibum or oil onto the surface of the eye. Blepharitis can lead to styes and chalazions. Management is with warm compresses and gentle cleaning of the eyelid margins to remove debris, for example using a cotton bud and baby shampoo. Next, let's talk about styes. Hordeolum externum is an infection of the glands of Zeiss or the glands of Moll. The glands of Moll are sweat glands at the base of the eyelashes. The glands of Zeiss are sebaceous glands at the base of the eyelashes. A stye causes a tender red lump along the eyelid that may contain pus. Hordeolum internum is infection of the meibomian glands. Compared with hordeolum externum, hordeolum internum tend to be deeper, more painful, and may point inwards towards the eyeball underneath the eyelid. Styes are treated with warm compresses and analgesia. Topical antibiotics, for example chloramphenicol, may be considered if it's associated with conjunctivitis or if symptoms are persistent. Next, let's talk about chalazion. A chalazion occurs when a meibomian gland becomes blocked and swells up. It's often called a meibomian cyst. It presents with a swelling in the eyelid that's typically not tender, however it can be tender and red. Treatment is with warm compresses and gentle massage towards the eyelashes to encourage drainage of the gland. Rarely, surgical drainage may be required. Next, let's talk about entropion. Entropion refers to when the eyelid turns inwards and the lashes press against the eye. This causes pain and it can result in corneal damage and corneal ulceration. Initial management is by taping the eyelid down to prevent it from turning inwards. Definitive management is surgical correction of the entropion. A same-day referral to ophthalmology is required if there's a risk to sight due to corneal damage or ulceration. When the eyelid is taped down, it's essential to prevent the eye from drying out by using regular lubricating eye drops. Next, let's talk about ectropion. Ectropion refers to when the eyelid turns outwards, exposing the inner aspect of the eyelid. It usually affects the bottom eyelid. Ectropion can result in exposure keratopathy, as the eyeball is exposed and not adequately lubricated and protected. Mild cases of ectropion may not require any treatment. Regular lubricating eye drops are used to protect the surface of the eye. More significant cases may require surgery to correct the defect. A same-day referral to ophthalmology is required if there's a risk to sight. Next, let's talk about trichiasis. Trichiasis refers to inward growth of the eyelashes. It results in pain and can cause corneal damage and ulceration. Management of trichiasis involves removing the affected eyelashes. Recurrent cases may require electrolysis, cryotherapy, or laser treatment to prevent them from regrowing. A same-day referral to ophthalmology is required if there's a risk to sight. Next, let's talk about periorbital cellulitis. Periorbital cellulitis, also known as preseptal cellulitis, is an eyelid and skin infection in front of the orbital septum, in front of the eye. It presents with swollen, red, hot skin around the eyelid and the eye. Periorbital cellulitis needs to be differentiated from orbital cellulitis, which is a sight and life-threatening emergency, which we'll talk about in more detail shortly. Patients are referred urgently to ophthalmology for assessment. A CT scan can help distinguish between periorbital and orbital cellulitis. Treatment of periorbital cellulitis is with systemic antibiotics, orally or intravenously. Periorbital or preorbital cellulitis can develop into orbital cellulitis, so vulnerable patients, for example children, or severe cases may require admission for monitoring. Finally, let's talk about orbital cellulitis. Orbital cellulitis is an infection around the eyeball involving the tissues behind the orbital septum. Symptoms include pain with eye movement, reduced eye movements, visual changes, abnormal pupil reactions, and proptosis, which is bulging forward of the eyeball. Orbital cellulitis requires emergency admission to hospital under ophthalmology and intravenous antibiotics. Surgical drainage may be needed if an abscess forms. Chapter 154. Conjunctivitis. Conjunctivitis refers to inflammation of the conjunctiva. The conjunctiva is a thin layer of tissue that covers the inside of the eyelids and the sclera. Conjunctivitis may be bacterial, viral, or allergic. It may be unilateral, affecting one eye, or bilateral, affecting both eyes. Let's start with the presentation. Conjunctivitis presents with a red, bloodshot eye, an itchy or gritty sensation in the eye, and eye discharge. Conjunctivitis does not cause pain, photophobia or discomfort with lights, or reduced visual acuity. Discharge covering the eye may cause blurry vision, but this should return to normal when the discharge is cleared away. Bacterial conjunctivitis presents with a purulent discharge, meaning pus coming from the conjunctiva of the eye. It's typically worse in the morning when the eyes may be stuck together with the pus. It usually starts in one eye and can spread to the other eye, and bacterial conjunctivitis is highly contagious. Viral conjunctivitis is common and usually presents with a clear discharge from the eye. It's often associated with other symptoms of a viral infection, such as a dry cough, sore throat, and a blocked nose. There may be tender, preauricular lymph nodes in front of the ears. Viral conjunctivitis is also contagious. Let's go through the causes of an acute red eye to look at the differential diagnosis for conjunctivitis. The causes of an acute, painful red eye include acute angle closure glaucoma, anterior uveitis, scleritis, corneal abrasions or corneal ulceration, keratitis, a foreign body in the eye, and traumatic or chemical injury to the eye. The causes of an acute, painless red eye, meaning a red eye without pain, include conjunctivitis, episcleritis, and subconjunctival hemorrhage. Conditions that require emergency same-day referral to ophthalmology tend to cause pain or reduced visual acuity. So these are the red flags that would indicate a referral is warranted. Next, let's talk about management. Conjunctivitis usually resolves within 1 to 2 weeks without needing any treatment, including bacterial cases. Hygiene measures can reduce the spreading, for example, avoiding sharing towels and close contact with others, and regular hand washing. Cleaning the eyes with cooled, boiled water and cotton wool can help to clear the discharge. Chloramphenicol or fusidic acid eye drops are options for bacterial conjunctivitis if necessary. Neonates, meaning newborn babies under 1 month of age with conjunctivitis, need urgent ophthalmology assessment. Neonatal conjunctivitis may be caused by gonococcal infection, which can cause serious complications, for example, permanent vision loss. Finally, let's talk about allergic conjunctivitis. Allergic conjunctivitis is caused by contact with allergens, chemicals that produce allergic reactions. It causes swelling of the conjunctival sac and the eyelid, with itching and a watery discharge. Antihistamines, either oral or topical, may help with the symptoms. Topical mast cell stabilizers, for example sodium chromoglycate, can be used for chronic seasonal symptoms of allergic conjunctivitis. For example, patients with hay fever who develop allergic conjunctivitis whenever the pollen count is high. Topical mast cell stabilizers work by preventing the mast cells from releasing histamine. They require several weeks of use before they show any benefit. Chapter 155. Anterior uveitis. Anterior uveitis refers to inflammation of the anterior aspect of the uvea. The uvea consists of the iris, the ciliary body, and the choroid. The choroid is the layer between the retina and the sclera. Intermediate uveitis and posterior uveitis are also possible, but they're less common than anterior uveitis. Anterior uveitis is usually caused by an autoimmune process, but it can also be due to infection, trauma, ischemia, or malignancy. Anterior uveitis involves inflammation in the anterior chamber of the eye. The anterior chamber becomes infiltrated by neutrophils, lymphocytes, and macrophages, which are all cells of the immune system. Hypopyon refers to a fluid collection containing inflammatory cells that's seen at the bottom of the anterior chamber of the eye on inspection. Let's talk about the associations. Anterior uveitis may be associated with an underlying autoimmune condition, particularly seronegative spondyloarthropathies, for example, ankylosing spondylitis, psoriatic arthritis, and reactive arthritis, inflammatory bowel disease, sarcoidosis, and Behçet's disease. A tom tip for you is worth remembering the association between anterior uveitis and the HLA-B27 gene and the seronegative spondyloarthropathies. These are all connected. Next, let's talk about the presentation. Anterior uveitis may present with symptoms of a painful red eye, and this is typically a dull, achy pain in the eye, reduced visual acuity, photophobia due to spasm of the ciliary muscles, and epiphora, which is excessive tear production. Examination findings include ciliary flush, which is a ring of red that spreads from the cornea outwards, miosis, which is a constricted pupil due to sphincter muscle contraction, an abnormally shaped pupil due to posterior synechia or adhesions pulling the iris into abnormal shapes, and hypopyon, which is a collection of inflammatory cells seen as a white fluid at the bottom portion of the anterior chamber. Finally, let's go through management. Patients should be referred for urgent assessment and management by an ophthalmologist. The usual first-line treatment is with steroids, either eye drops, oral or intravenous, and cycloplegic medications, for example cyclopentolate or atropine eye drops. Cycloplegics dilate the pupil and reduce the pain associated with ciliary spasm. Cycloplegic refers to paralyzing the ciliary muscles. Cyclopentolate and atropine are antimuscarinic drugs that reduce the action of the iris sphincter muscles and the ciliary muscles. Recurrent cases of anterior uveitis may require treatment with DMARDs or anti-TNF medications. Chapter 156. Episcleritis. Episcleritis involves benign and self-limiting inflammation of the episclera, which is the outermost layer of the sclera just below the conjunctiva. Episcleritis is relatively common in young and middle-aged adults. It's often associated with inflammatory disorders such as rheumatoid arthritis and inflammatory bowel disease. Episcleritis is not usually caused by infection. Let's start with the presentation. Episcleritis usually presents with an acute onset of unilateral symptoms of localized or diffuse redness to the white of the eye, often with a patch of redness in the lateral sclera, which is the outer part of the white of the eye, towards the ear. There's usually no pain or maybe a mild discomfort, and there's dilated episcleral vessels. Importantly, there's no photophobia and no discharge from the eye, and a normal visual acuity. Photophobia, discharge, or reduced visual acuity are more suggestive of scleritis rather than episcleritis. Applying phenylephrine eye drops helps to differentiate between episcleritis and scleritis. Phenylephrine will cause blanching of the episcleral vessels, which causes the redness to disappear in episcleritis. Phenylephrine does not affect the scleral vessels, and so it won't make any difference to the redness in scleritis. Finally, let's talk about management. Episcleritis is usually self-limiting and it will resolve without any treatment in 1 to 2 weeks. No treatment is necessary. Symptoms may be relieved with analgesia, for example ibuprofen, and lubricating eye drops. More severe cases may be treated with steroid eye drops. Chapter 157. Scleritis. Scleritis refers to inflammation of the sclera in the eye. The sclera is the outer layer of connective tissue surrounding most of the eyeball, excluding the cornea at the front of the eye. It forms the visible white part of the eye on inspection. The most severe type of scleritis is called necrotizing scleritis, which can lead to perforation of the sclera. Most cases of scleritis are idiopathic with no clear cause, or associated with an underlying systemic inflammatory condition. Less commonly, it can be due to infection, for example Pseudomonas or Staphylococcus aureus infection. Scleritis is more common in women. Let's talk about the associated systemic conditions. There's an associated systemic inflammatory condition in around 50% of patients presenting with scleritis. It's particularly associated with rheumatoid arthritis and vasculitis. The type of vasculitis most associated is granulomatosis with polyangiitis. A Tom tip for you: the connective tissue of the sclera is relatively similar to the connective tissue in joints, so it may be affected in rheumatoid arthritis. It's worth remembering the difference between the conditions associated with scleritis, which are rheumatoid arthritis and vasculitis, and the conditions associated with anterior uveitis, which is the seronegative spondyloarthropathies, such as ankylosing spondylitis, psoriatic arthritis, and reactive arthritis. Let's go through the presentation. Scleritis usually presents with a more gradual onset of symptoms. It can be unilateral or bilateral. Features include severe pain in the eye, which is typically a boring type pain, worse with eye movement, photophobia, epiphora, which is excessive tear production, red, inflamed sclera, which can be localized or diffuse, congested vessels on the sclera, reduced visual acuity, and tenderness to palpation of the eye. Finally, let's talk about management. Patients should be referred for urgent assessment and management by an ophthalmologist. They should be assessed for an underlying systemic condition, such as rheumatoid arthritis or vasculitis. Management in secondary care may involve nonsteroidal anti-inflammatory drugs given orally, steroids, which may be topical or systemic, immunosuppression appropriate to the underlying systemic condition, if there is one, for example, methotrexate in rheumatoid arthritis, and antimicrobial treatment where infection is present. Chapter 158: Corneal Abrasions. Corneal abrasions are scratches or damage to the cornea at the front of the eye. The cornea is the outer surface layer that sits in front of the anterior chamber, the iris, and the pupil. Common causes of corneal abrasions include damaged contact lenses, fingernails, foreign bodies, for example metal fragments, tree branches, makeup brushes, and entropion, which is an inward-turning eyelid. Chemical abrasions, for example from acid, can cause severe damage and vision loss, and these require immediate extensive irrigation to wash away the chemical and ophthalmology input. Abrasions associated with contact lenses may involve Pseudomonas infection. An important differential diagnosis is herpes keratitis, which requires antiviral treatment. Let's talk about the presentation. There's often a history of trauma to the eye, followed by a painful red eye, photophobia or discomfort with lights, a foreign body sensation as though there's something stuck in the eye, epiphora, which is excessive tear production, and blurred vision. A fluorescein stain can be applied to the eye to help diagnose a corneal abrasion. The fluorescein stain is a yellow-orange color and it collects inside abrasions or ulcers, highlighting them, particularly when they're viewed under cobalt blue light. Finally, we need to cover management. Mild, uncomplicated abrasions may be managed in primary care where there's appropriate expertise and skill. Uncomplicated corneal abrasions usually heal over 2 to 3 days. More complicated cases require assessment and management by ophthalmology. Management options include removing any foreign bodies, simple analgesia, for example paracetamol, lubricating eye drops, antibiotic eye drops, for example chloramphenicol, and close follow-up. Lubricating eye drops vary in their viscosity. Hypromelose eye drops are the least viscous, and the effects last around 10 minutes. Polyvinyl alcohol drops are the middle viscous choice, And carbomer drops are the most viscous, and the effects last about 30 to 60 minutes.